Check, check.
Yeah, wonderful.
All right, thank you. Boom, boom.
Ja. Schönen guten Morgen, liebe Kolleginnen, liebe Kollegen, sehr geehrte Damen und Herren. Ja, ich habe heute Morgen auf der Hinfahrt kurz überlegt, tolles Wetter, tolle Menschen, tolle Veranstaltung, viel Spaß mit allen und unser Motto, was wir alle gelernt haben, Conference of Friends, die Konferenz der Freunde. Und wir werden das nächstes Jahr wieder machen. Ich bin damit ziemlich sicher, dass wir hier Freundschaften nicht nur fachlicher Natur, auch menschlicher Natur gefasst und geschaffen haben. Werte, die wir erhalten müssen, zumindest die nächsten Jahre, solange wir noch die Zecken haben und auch andere Infektionserreger und auch andere Themen in der Welt. Ja, in diesem Sinne möchte ich noch zwei hervorragende Buchautoren euch kurz vorstellen. Hans-Peter Gabel und Petrop Seidel, kommt ihr mal kurz nach vorne zu mir. Beide sind die Urgesteine der Borreliose. Ich weiß gar nicht, wie viele Jahre ihr beide schon arbeitet.
Also Borreliose 2000 und das Buch ist 2008.
Ja, also schon 23 Jahre. Da können wir in 2 Jahren das silberne Hochzeit da feiern. Und Hans-Peter, du?
Ja, 30 Jahre und ja, seit dem Studium halt mit Borreliose bzw. mit Lyme Disease behaftet.
Da gab es schon Zecken, oder?
Da gab es schon Zecken, ja.
Eieiei. Ja, also die beiden, die haben Bücher geschrieben und wenn ihr Zeit und Lust habt in der Pause, stehen beide auch für Signaturen der Bücher. Wir haben den Tisch nach unten geholt, sind einmalige Gelegenheiten, euch beide zu haben, eine Widmung auch noch vielleicht zu ergattern von den Urgesteinen der Lyme-Disease-Szene. Vielen Dank, dass ihr da seid und bitte geht an die Tische, wenn es geht. Ja, Professor Dr. Kunal Garg, Jyväskylä University, hervorragender Wissenschaftler. Ich glaube, man kennt ihn inzwischen in der wissenschaftlichen Szene, viele Publikationen geschrieben im In- und Ausland. Sein Schwerpunkt ist auch die Zecke geworden, interessanterweise. Finnland, ob es Zecken gibt, kann er uns gerne beantworten. Ja, sein Vortrag wird heute sein, immer mehr emerging, dass wir immer mehr wissenschaftliche Arbeiten leistet bei der persistierenden Lyme-Borreliose. Vielen Dank und ein herzliches Willkommen dem Professor Garg.
Thank you, Dr. Raman. All right, good morning. We are here on a Sunday morning to talk about a bacteria. It's quite interesting. So this presentation was initially to be presented by Leona. Unfortunately, she could not be here, so I'll be doing this on behalf of her. I also have a vested interest in Tester, so this is just a disclosure agreement. In the presentation today, I will be taking you through a few different things, understanding why we actually do research in this area. Borrelia is a very unique bacteria, so we will be looking at some of the characteristics of Borrelia that make it stand out compared to other bacteria. I will be sharing some of the recent findings in the literature, and finally also propose a future direction for the research that we will be doing, and you'll probably see in the next presentations. Well, the reason why we do the research over here is because the disease is spreading. By 2050, estimated 2.8 billion people will suffer from tick-borne disease, which is essentially 35% of the world's population. And last year, as many of you already know, there was an article that showed that 1.2 billion people, which was 14% of the global population, has already shown an antibody response to Borrelia. And we have an estimate of 2 million people that are long haulers or people with persistent symptoms in their late stages. someone always knows someone with this disease. Many of you might be patients yourselves. Many of you are patients and physicians. And this is a unique combination of audience members we usually see in this disease, that people are suffering from chronic Lyme disease. So when we're talking about Lyme disease or tick-borne diseases, essentially in North America and in Europe, we are talking about the three most common species: the Burgdorferi sensu stricto, the Afzeli, and the Guarini. In rare cases, there are infections relating to Bissetti, Spilmani, and other Borrelia species, but these are the three main species that we see in North America and in Europe. And it is very important to appreciate why we talk about these three different species, because while yes, they are Borrelia species, they have a very different target area in the host. So for example, the Burgdorferi sensu stricto is more arthritis oriented, whereas the Afzeli is more skin oriented. So that is where we have diseases like acrodermatitis. And finally, we have Borrelia guarini, which is mostly neurotropic, and that is why we have it playing an important role in Lyme neuroborreliosis. So if we just start at the beginning, how the Borrelia keeps on persisting, it really starts from a larva tick feeding on a infected vertebrate. Then the larva tick with the Borrelia from an infected vertebrate would grow into a nymph, and the nymph can also then feed on infected vertebrate, but at this stage it can also feed on hosts, so a blood meal. Then the nymph would grow into an adult, and it usually at this stage feeds on larger vertebrates like deers, and then it finally lays eggs, and then the cycle keeps on continuing. One of the most important things to note over here is that Borrelia throughout these different feeding stages is retained within the tick, and when it comes into the host, there's a probability that it can be transmitted to the host. And there is interesting research now to suggest that ticks might not be the only carriers of Borrelia. There is an expanding vector sources for it, such as mosquitoes and other blood-sucking flies. So Borrelia is a very unique bacteria, as I said in the beginning of my presentation, and there are many reasons for that. So it has a linear chromosome, and this is unusual for a prokaryotic organism. This is usually reserved for a eukaryotic organism. It has a high degree of genetic redundancy, which essentially means that it has multiple copies of the same genes. So if a certain gene gets inactivated, that does not really hinder it from performing its functions. It has a large number of circular and linear plasmids, and the reason why this is because it allows Borrelia the flexibility to adapt to its immediate environment. And what would be the immediate environment? Well, it would be the host immune response. But it seems like Borrelia has conveniently forgotten to carry any metabolic genes to perform basic cellular functions like replication, transcription, and translation. And so what Borrelia does is that it depends on its immediate environment for nutrients. Unlike other bacteria, Borrelia does not have a traditional gene for virulence, but it has a lot of outer surface proteins which play an important role in interacting with the host immune system and immune evasion. Finally, Borrelia is a gram-negative bacteria. Although that is the case, it does not have a lipopolysaccharide. It has a pseudo gram-negative wall, which essentially means a thin layer of peptidoglycan. And this is a very important thing, which Leona would say, is that if you're doing microscopy, be very careful with the PI dye, the propydium iodide dye, which is usually used to mark cells that are dead. In the case of Borrelia, that does not apply because it has a pseudo gram-negative cell wall. The propydium dye can still go inside a live Borrelia. So if, for example, if you're doing studies on antibiotics or herbal substances and their interaction with Borrelia, and you say, well, I've induced a herbal substance on Borrelia and now I see red, that might not be true because the propydium iodide still stains live Borrelia. And finally, Borrelia within its outer and inner membrane has flagella, which essentially gives it the corkscrew structure. The other thing that makes Borrelia unique is its nature or superpower of pleomorphism. And over the years, the pleomorphic Borrelias have been called many different names: L forms, spheroblast, cyst, cell wall deficient. And these are just literature to show that in this area the research has been active, but mostly the terminology has been heterogeneous. So over the next few slides, I'm trying to bring evidence to show that these are not cell wall deficient forms. These are actually forms that have a cell wall. But before I get into that, it is unique to appreciate how Borrelia kind of plays with its size when it is undergoing pleomorphism. It is usually between 10 to 30 micrometers, and then it reduces its size to 0.8 to 1.7, and then it further reduces its size when it is in round body form to 2.4 to 3.2. So there is a big difference in its size when it is doing the pleomorphism. So there are two questions that arise: what induces a Borrelia round body, and does it have a outer and inner membrane? So on the left-hand side, you can firstly see spirochete. So the spirochete has a protoplasmic cylinder, as we all know. It has an inner membrane and it has an outer membrane. And what can induce a spirochete into a Borrelia round body is water, for example. And you can see that these are round bodies induced by water. And you can see that this round body has a protoplasmic cylinder, it has an outer membrane, and it has an inner membrane. So Borrelia round bodies are not cell wall deficient. They do indeed have a surface membrane. In addition to water, there are many different unfavorable conditions that can push the Borrelia to move into a round body from a spirochete, and one of that is human sera. So human sera also induces a Borrelia spirochete to turn into a Borrelia round body. So this essentially points towards that this can happen in host immune systems also. Here is some more evidence. So we will be looking at the outer and inner cell walls of the Borrelia in terms of flagella, because if the outer and inner membrane are not there, then the flagella cannot be localized in usually between the cell walls. But we see that, for example, in spirochete, the outer and inner membrane you can see, and then you can see flagellas, the dots, because it's a cross-sectional electron microscope image. And then you can see the same in round body. You see the membrane, and then you can see localized flagella. So there are outer and inner membrane, and we see the flagella carrying on from the spirochete to the round body structure. Then we have the P41 immunolabeling, which is quite common to see the cell wall of the Borrelia spirochete, but we also see that there is positive labeling in the round bodies, which essentially again pushes to the notion or pushes to the evidence that there is a cell wall, and a cell wall means there will be an antibody response. So Borrelia, once it reverts into a round body, that is not in many ways the end of the story, because it can revert back to a spirochete, as you know. And here is a video if it plays. So you can focus on this one, and this is in a round body form at the moment, and you can see that it will uncoil. So I will just play this. And you can see that it has uncoiled. So I can just play that again. So it's in the round body structure, and then it will uncoil. So Borrelia has this ability to uncoil, which essentially gives it the mechanism to stay dormant in the round body form, but then revert back to the spirochete and actively reproducing form when the conditions and surroundings are favorable. So this is an experiment wherein it shows how Borrelia uses ATP or does not use ATP, because a bacteria not using ATP would be a signature for dormancy. So we have a positive control here, which is the spirochete itself, and we know it is actively reproducing, and it is using ATP, as you can see. And as a negative control, we have doxycycline and methanol, which essentially either damage the cell wall of the Borrelia round body or kill the bacteria all itself. So we induced the bacteria for 10 minutes in the round in water, and then we put it back into its medium, which is favorable, and you can see that after 5 days it starts using ATP again. And this is not in the round body form anymore, it is in the spirochete form, and that is why we can see that the reversion was successful. And this is not just at 10 minutes, it can go up till 2 hours. So on the right hand side you can see that when the bacteria was induced into round bodies and was kept for 2 hours and then put into the medium, after a little later, 5 to 7 days, it reverses back in the spirochete form, and it can start using the ATP. So as I said, since there is a outer and inner membrane, we can expect to see the antibody response. So this is just a proof of concept study that was done to show in S, that is the spirochete, and in RB, that is the round body. And you can see that in both cases, the Lyme positive patient has been responding to both of these antigens. But of course, we wanted to do a few larger studies, see how patients from different groups are responding to the round body. So this is one of the largest studies that we have, and you can see that there are 3 species of persistent forms that we have over here. We have the Burgdorferi, the Afzeli, and then the Guerini persistent forms. And yes, we see for IgM antibody, we see that in the CDC acute patients are responding to the persistent forms, and in the late stage in IgG there is also response. But what really pops out, I have to say, is the response by the post-treatment Lyme disease syndrome patients. In IgM, we see almost 45% of patients responding to Borrelia afzeli persistent forms, and this continues in IgG also. So we are seeing the relevance of what the antigen stands for. So Borrelia round bodies should be markers for a later stage of the disease, and we are seeing, for example, in post-treatment Lyme disease, that Borrelia as an antigen is valuable. This is another study that we did in Finland with a lab, and this was to see if patients during the 2021 summer that were suffering from Lyme disease and that were not suffering from Lyme disease but had these summer flu symptoms or febrile symptoms, are they responding to Borrelia antigens? And you can see firstly that in most cases we do not see a lot of response to co-infections and opportunistic microbes, but we do see response to the spirochete Borrelia and the round body Borrelia. So this again indicates that using such antigens, we can reduce misdiagnosis if we just add a screening step. Finally, this is a study that is actually in peer review. I'm hoping that the journal will give us feedback soon. But this was a study with the Royal Sydney Hospital in Australia, wherein we wanted to compare the response by Lyme-like patients in Australia to reference samples patients essentially from France and the US. So we had 32 reference samples and we had 20 specimens in Australia, and a few of these were already tested positive for Lyme disease with a different test. So it was a little surprising that in IgM, we see that the patients with Lyme-like symptoms in Australia had much higher response than the reference samples patients from Australia and France. And this continues not only in IgM and also in IgG. So we are seeing the need for this antigen in underserved areas, especially where the screening for Lyme disease is not so common. This is a recent article, and there are 2 reasons why we have this in the presentation. Firstly, if you remember in the initial slides, I mentioned that the pleomorphic structures of Borrelia have been called very many different names, cysts, cell wall deficients. But in this 2023 study, you can see RBs. So we are reaching a sort of consensus in the literature that these are round bodies, and the consensus that round bodies do actually have a cell wall. So what this actually shows is the transcriptomes of round bodies, which is RB, the Borrelia blebs, and then BF is the biofilms. How the transcriptomes of the spirochete change from spirochete to round bodies, spirochete to blebs, and spirochete to biofilms. And what the researchers have shown over here is that there is not a lot of difference between the transcriptomics for spirochete and round body, but there is a lot of difference in transcriptomics when it is a bleb. which is the intermediate between the spirochete and the round body. And specifically, the difference in transcriptomics relates most to genes that are related to immune evasion or the addition of the cells. So where exactly is the research going? So in the recent times, what we're trying to do is we're trying to understand how these different structures of Borrelia interact with different cell lines such as macrophages, cancerous cells such as chondrosarcoma, and non-cancerous cells or skin cells like the dermal fibroblasts. And the essential hypothesis is that Borrelia will have a different way interacting with cells. It will have different strategies to survive. And I think we have some interesting results over here. So firstly, on the left-hand side, so this is a helium ion microscopy image. And what this is showing is the chondrosarcoma cell when it was infected with Borrelia. So you can see the cell surface, and then the Borrelia, and then the dermal fibroblast cells that were again infected with Borrelia. You would expect that although the cell types are different, the bacteria is the same, so the interaction of bacteria with the cell should be the same. That is not the case. In the left, you can see, and also over here, you can see that the 100% of the cells that were interacting with the chondrosarcoma cell or the cancerous cell were mostly in the spirochete form, in the actively reproducing form. But in the fibroblast cells, we were seeing coiling. It's a helium microscope image, so you don't see the cross section. But this is a coiled Borrelia or Borrelia round body. So Borrelia can change its shape when it is interacting with the cell surfaces for invasion. So macrophages and many other studies have shown that macrophages can take up spirochetes and round bodies. So I have a video over here on the left-hand side which shows the co-localization of macrophage and macrophage nucleus and the spirochetes, and then on the right-hand side, the co-localization of macrophage with round bodies. So it's a little fast, the video, so I'll play it a few times. So you can see that in blue, we had the nucleus, and in green, we had the Borrelia on it. So this is a Z-stack image. I'll just play it again, if I can find the, yeah. So in blue, we have the nucleus, and then we have the Borrelia co-localizing with the nucleus, which essentially means that macrophages can take up spirochetes. And it's the same for round bodies. And again, you'll see round bodies in green. Oh, sorry. So you can see that the round bodies are really in the macrophages. So macrophages can, and other cell types can take up spirochetes and round bodies efficiently, but what really happens after that? So this is also another just static image. You can see the nucleus, and then you can see the spirochetes and a few round structures, round body, and then also over here you can see round bodies inside the cell. So what really happens once the pleomorphic form is inside the cells? One of the things that happens is that the nature of pleomorphic cells is not the same across different cells. So in the chondrosarcoma cells, you can see that we see a lot of round bodies up to 96 hours of infection, and after that it falls. We have damaged cells, we don't have anything. But up to 96 hours, you can see in these checkers that there's an increasing amount of Borrelia round bodies. But in the fibroblast dermal cells, you see clearly that there's a lot of spirochetes, not round bodies. So different cells have helped Borrelia adapt to different pleomorphic structures. The other thing that you see over here is that when the Borrelia is inside the cell, the usual literature or the previous literature has shown that it induces cell death. But in a recent paper from our lab, it has shown that it actually does not induce cell death. So you can see over here on the top the chondrosarcoma cells, you can see the cell nucleus, and you can see in green the bacteria. And on the bottom also you can see the fibroblast cells, you can see the nucleus, and then the bacteria. And This essentially means that there is a nature of intracellular persistence by Borrelia in these cells. And it is going up to 9 days. So the cells were alive and the Borrelia was alive for 9 days. But this figure does not show that both were alive. So I can show you a little more data. Okay, so we wanted to really check if the cell was alive. In the microscopy image, it was clear that Borrelia was inside the cell, but and the cell was looking alive at least. So to see if the cell was really alive, we checked the ATP function or mitochondria of the cells, and you can see that the fluorescence of the mitochondria as the infection increases, the mitochondria activity is not going low, and it is very much comparable to infected cells and the uninfected cells. So cells that were infected with Borrelia were just growing as uninfected cells. So there was no cell death, at least in this experiment. And so the previous results were inconsistent with the previous findings, wherein the other researchers have shown that Borrelia would induce cell death, whereas papers from our lab show that Borrelia does not induce cell death. But what is consistent is that once you try to regrow the Borrelia from the Borrelia that were inside the cell, you can see that the Borrelia grows back. So it's really a state wherein Borrelia is able to infect the cell. It is inside the cell. It is not inducing cell death. But when you try to grow the Borrelia back, it is growing back. So you can see that there are some cells that show no growth, but then there are other cells that do show that there is growth. And this is just another way of showing that there are a lot of cells that are for the chondrosarcoma cell show that there are viable cells. These are not dead cells, so the cell death is not being induced, whereas in dermal fibroblast cells, the cell death is also not being induced. Sorry, one of the points I missed over here is that at this point, we started looking into the Borrelia burgdorferi outer membrane vesicles, and this was an interesting thing to see if these could induce cell death, because the outer membrane vesicles are sometimes playing a role in cell death, but they do not. So one of the interesting things I think we will be pursuing in the future is the outer membrane vesicles of Borrelia. And what you can see over here is that the 3, 4, and 5 are 3 different essentially outer membrane vesicles of Borrelia, and what we've essentially done is we've labeled them with the same label that we use for outer surface protein membranes on Borrelia spirochetes. And we see some of the same properties. Firstly, we see P39. Then we see anti-Borrelia burgdorferi antibodies also reacting to these, which essentially means that there will be patient immune response to this. OSPA antibodies are responding to the outer membrane vesicles, and OSP antibodies are also responding. So this could be an antigen for diagnostic utility, which we will be looking into more in the future. So overall, Borrelia is able to use the cell surface and interact with it separately, which essentially means that it is sitting inside the cell, not killing the cell, and this is a method of immune evasion. It is a method of intracellular persistence. For the future, we want to study more the outer membrane vesicles, how it relates to clinical knowledge, how it can improve diagnostics essentially. Thank you.
Thank you, Professor Garg. It was so fascinating what you did here. ATP, I speak in German, then I translate, because you understand. Das ist ja so interessant mit dem ATP, wenn ihr euch das überlegt. Warum sind die müde? Hat er klar gezeigt. Wenn die in der Round-Body-Form sind, patients are not tired. But when it's get active, using ATP. So it's the same with SARS-CoV-2. Die haben alle das ATP. Ist doch klar, deswegen sind die erschöpft, die Patienten. Das ist doch langsam Conclusions. So the ATP is sucked away from Borrelia,
Yeah.
from the active spirochete. It's a wonderful. I was shocked about the Australian situation that you said it's not tick-borne-like illness. It's really
Yeah.
antibodies you found, correct?
Yeah, we did. We had to be a little political in the article. We had
I
to
know.
say like disease and not Lyme disease.
There are ongoing studies. Maybe
Yeah.
internally they want to check the ticks correctly
Yeah.
with a PCR. Yeah, and sorry, Entschuldigung, dass ich da, aber ich bin da fast überwältigt über diese ganzen, mir kommen da fast irgendwie die Tränen. Wir haben einen Patienten mit Sarkom und da müssen wir unbedingt nach Borrelien nochmal checken. Ist schon untersucht, ob wir dann die Borrelien mit dem Sarkom, is this a cell line you're using with the chondrosarcoma? Or
Yeah,
is
it's
it,
a cell line. It's SW, I don't remember.
it was not a clinical study.
No, it's
so-
not a clinical study. It was an in vitro proof of concept.
Okay,
Yeah.
but why not in vitro, in vivo?
That would be the next stage.
The
So,
cancerogenous potential, das kanzerogene Potenzial dieser Erreger, was ja auch beim Glioblastom schon von Alan MacDonald und vielen Gruppen erarbeitet wurde. Also wir haben hier einen Wissenschaftler, der an der Vorfront mit Eva Sapi war und das 2015 mit Maryline, das ist eine so wichtige Arbeit. Und sie wird immer mehr zitiert. This work you did is, and Maryline and
Yeah,
Leona
Leona.
Gilbert. Leona is not, unfortunately not
Yeah.
here. She's living Borrelia, Miss Borrelia here in
Yeah.
the Lyme community. But this was a groundbreaking work, what
Yeah.
you did. I think now it's clear, round bodies, everybody is, jeder zitiert das auch. Es gibt eine neue, ganz neu, kann ich euch sagen, Rich Horowitz hat eine Dapson-Studie jetzt gemacht und bezieht sich genau auf diese round bodies. Rich Horowitz published, I think yesterday or so, the study came with dapsone, and he cited the round
Yeah,
bodies. So
yeah.
everybody's now round bodies, round bodies. Das ist ja eine fantastische Sache. How can you test the round bodies? That would be my question.
yeah, well, we have developed a test because we were able to isolate it. We've put it in a test called TickPlex. And of course, Armin Labs is using it, and there are many other labs that are using it. So it's a serology test. As you order any Lyme test, you can order TickPlex. It's the same procedure. Yeah.
Thank you, because I think every patient needs to be checked
Yeah.
for persistiforms.
Yeah.
And to confirm this,
Yeah.
in the clinical aspects, we find so many with negative Western blots, but positive TickPlex.
TickPlex. Yeah.
This fills the gap. Das schließt die Lücke im Endeffekt, muss man sagen. Es müssen alle mit diesen Round Bodies. This nothing against just tested, but there should be a development of more round body
Yeah,
tests to
there
compare
should
them in the accredited laboratories. So da müssen mehr TickPlex noch entstehen in der Methode. My last question, then you could ask Professor Gar, because we have little time, so you were fantastic fast also in your highly scientific presentation here. Great, thank you. From Leona originally, I know you're substituting her today. Thank you very much. Gibt es einen Biofilm-Test? How can we test the biofilms? Not you in your scientific lab, but for us. Wie können wir irgendwann die Biofilme, that's my last question, biofilm test. Could you bring such a test into routine for all the pathogens, a biofilm test? Wir brauchen einen Biofilm-Test.
Yeah, so we are trying to find a way to isolate biofilms because biofilms have an extracellular matrix which is not really unique to Borrelia. So we need to find unique proteins within the Borrelia biofilms, and that's an ongoing research at the moment, but should be in the future.
So, Fragen jetzt bitte? Bitte fragt einfach. Also ich finde das so, Peter, du hast bestimmt Fragen.
Yes, I'm still wondering about Australia. Why don't they accept your results? I mean, they must acknowledge that they have Borrelia in the country for many years already, and there's even a patient organization. And I wonder why the political system is so stubborn.
Yeah, it makes you wonder, right? That's true. It is definitely there, and it's an ongoing battle, I think. But the patient advocacy groups, as you said, LDAA, for example, they're working very hard, and there is good response from hospitals, actually. They are taking an active role in doing this research. But I think the amount of funding that you would require is quite low compared to what you even see in Europe, for example. So I think once the funding goes up, the interest in research would go up, and you would see more evidence coming out. Yeah.
Okay, there are not so many questions.
Okay.
Maybe I discuss with you. We have 2 minutes
Yeah.
more, a round table, both of us. What does it mean clinically if you have a round body IgM? Was ist die Bedeutung, wenn man ein round body IgM Antikörper präsentiert?
Yeah.
I have that.
Yeah.
So what is now my consequence?
So an IgM persistence can happen in some patients, and round body related IgM would be very unique if there's active symptoms, if the patient has active symptoms. And from a lab test, round body IgM with a low CD57, for example, would usually relate to patients having symptoms. But if a patient has an IgM, no symptoms, I don't think that is a cause of concern, but it is a cause of continuous monitoring, I think. So just to keep tabs on the symptoms from time to time.
So we expect the switch from IgM to IgG. Erwarten wir den Wechsel von die Serokonversion?
Because there is IgM, I don't think there might be a switch to IgG because it is a hyper IgM or a IgM persistence in this patient. So I would think there might be an IgG if there's a reversion of the round body, as we've seen that the round bodies can revert back. So then there might be an IgG to spirochete. So it might be IgM persistent form positive, but then spirochete IgG positive.
Should be worth for clinical study.
Yeah, I think so, because because if a patient is IgM negative for spirochete, you're just ruling it out as Lyme negative, but if it is persistent form positive, you cannot do that anymore.
So any other more questions? Otherwise, we would give him a really warm welcome.
Yeah.
You are here around us. Thank you.
Thank you.
You will come back. Thank you.
Yeah.
Thank you very much.
Thank you.
Yes, we have a fantastic line of speakers, so I'm overwhelmed myself a little. This internationally, it's a high quality. If you go to different conferences around the world, such a quality of all speakers we don't have in this, what I can mention. And the next high quality will be Maja Oprovac-Klisic.
Hey.
Oh, I did it correct. I think you're from Zagreb, right? And nearby Zagreb, so she came also far away to us. Maja is a leading nutritionist in the field of fertility in Croatia and the region. She graduated in human nutrition from the Faculty of Food Technology and Biotechnology, University of Zagreb in 2009. Her approach to understanding nutrition regarding health and disease was always holistic. After 6 years as the head of the Food and Dietetic Department at the Clinical University Hospital Rijeka, it's a wonderful city at the ocean.
Adriatic coast, yes.
Okay, so we come there to you. And a lecturer at the Faculty of the Health Studies, University of Rijeka, Croatia. She moved to Germany, where she worked as a nutritionist in Agapleschen Diakoni Klinikum Hamburg. So on the northern part, you switched away from the southern parts to the northern parts. The technique, so you have a little time, I introduce you a little longer. A year after, she started her own business, consulting couples to optimize their nutritional status while dealing with infertility. Besides supporting her clients, she established a channel for teaching health professionals in the region to recognize the importance of nutritional status in achieving optimal fertility and treating infertility. Her main field of interest is PCOS. I think you will explain what it is. Endometriosis, we know, recurrent miscarriage and adhesion-related issues. Her passion is to empower women to know their menstrual cycle and gain inner power through symptothermal methods. Very, very good. And optimal nutritional status. Having enough energy for the day and trusting our body's ability to thrive gives people the chance to chase the fertility dreams most often without invasive IVF technologies. So the topic will be today research and experience in treating infertility, intestinal health, and the effect of lamprokinase. So give her a very warm welcome. Maja, thank you.
Good morning to you all, and it's such a great pleasure to be here, and thank you, Armin, for having me. I hope this talk will give you some useful and interesting insights for your practice and your knowledge. What we are going to talk about is my personal experience and my professional experience with lumbrokinase and fibrinolytic enzymes and intestinal health correction regarding infertility. So basically, we are going to talk about what is infertility, and how can, in that sense, lumbrokinase help. It's blocked fallopian tubes, it is endometriosis, it is adenomyosis, it is recurrent pregnancy loss, it is Asherman syndrome, a syndrome I will explain later. So, in general, female and male infertility. Why am I even talking about this topic? I come from Croatia. This is River Korana from my hometown Karlovac near Zagreb. I am a nutritionist and I have a practice in optimizing my clients that are trying to conceive. I'm optimizing their nutritional status. So collaborating with their OBGYNs and endocrinologists. And I also have my personal experience in this area that I will share. So I'm highly motivated to really change the way how infertility is being treated. Because I will show you there is so much just cutting out and just only surgery and just only birth control pills, so hormonal control of menstrual cycle, and we have so much actually to offer. So fibrinolytic enzymes are actually agents, components helping us dissolve clots. They lower blood viscosity and reduce platelet aggregation. What is interesting to me, besides of their anti-tumor activity, is this strong anti-inflammatory activity and strong fibrinolytic activity. There are different fibrinolytic enzymes, and maybe you have heard that in the context of cardiovascular disease management. You see, in 1990s, we saw in the research, okay, there's this novel approach to cardiovascular diseases and thromb management and thrombolytic therapy. And in the beginning, it was streptokinase and urokinase as fibrinolytic enzymes. But then we see in last few years, especially booming in this and 2022, the topic of lumbrokinase being used as fibrinolytic enzyme to dissolve adhesions, those intra-abdominal and intrauterine adhesions. The drawback of that first line fibrinolytic enzymes like streptokinase, nattokinase, ceratopeptidase or serapeptidase is that they do not have the limit. If we take the higher dose, it could lead to hemorrhage. But lumbrokinase is a fibrinolytic enzyme that also dissolves clots. It has high anti-inflammatory activity, also like, for example, serapeptase. But it dissolves only excessive fibrin, so there is no danger from hemorrhage and bleeding. It is actually quite long here. It is a over 2,000 years known traditional Chinese medicine drug. And we have nice meta-analysis showing its safety. In regards to infertility, why is it so interesting to me? Because if we see uterus and the wishing pregnancy, so PCOS that Armin mentioned is actually polycystic ovarian syndrome and endometriosis. Those two conditions are main reason why of female infertility. both of them have some kind of estrogen dominance. So those are basically all of my clients, PCOS and endometriosis women, being highly inflamed, highly nutrient depleted, and infertile. Clinical picture is different for every of those conditions, but the thing is, if we have nutrient depletion, if we have chronic inflammation, systemic inflammation, impaired immune response, we have that in endometrium, which is this inner lining of the uterus. And if that endometrium is inflamed, it is not receptive for fertilized egg cell. So this is the first moment where inflammation and poor gut health can lead to infertility, because if the egg gets fertilized, and if it comes to endometrium to implant, it won't be able to implant because endometrium is not receptive. If we take in the anti-inflammatory supplementation plan and anti-inflammatory lifestyle, we can improve this stage pretty good. Later on, if we get the implantation, the placenta forms, fetus develops, but what we see is if they do get a pathohistological examination of the placenta, often we see thrombosis and clots in the placenta, and obviously blocking the oxygen and nutrients coming to the fetus, and we lose the pregnancy. If the pregnancy moves on from that stage, what bad thing can happen is pregnancy loss in a later pregnancy, so in second or third trimester, or long-term malformations of the child because of adhesions that form within the uterus, and they could form on different places. If they form like here on the side, or in the cervical canal, it is not that bad. Sometimes the hysteroscope can push through these adhesions if they are not dense. But if they are here in the middle, they basically are stalling the space for the fetus to develop properly. Adhesions are web-like scar tissue. It is fibrin tissue. So fibrinolytic enzymes simply dissolve fibrin. Adhesions are supposed to be a norm, or are a normal part of inner wound healing. If there is a tissue injury from a surgery, abdominal or pelvic surgery, it will be physiologically to form some adhesions. But what we see in the state of chronic inflammation and some other factors, abnormal adhesion formation. And that then leads to infertility, different kinds of pain, ovulation, menstrual pain, hip pain, bowel obstruction, and so on. So obviously the process of adhesion formation is very complex, and these numbers then do not surprise us. This is a global consensus of experts on adhesions, and the numbers are, it's just, I'm speechless. 66 to 95% of people form adhesions after abdominal or pelvic surgery. This is just crazy. Up to 60% of surgeries in the world are repeated surgeries, probably because of the complications due to adhesions. 1 in 4 patients gets readmitted within 5 years because of the adhesion complications. And the only thing, like Dr. Greenland said with dementia, the only thing we have to treat this today is some barrier techniques or anti-adhesive drugs. And you will see later on what everything can we do with fibrinolytic enzymes actually, and anti-inflammatory protocols. So basically, we know that tissue trauma leads us to adhesions. That is any abdominal surgery. It could be C-section, it could be cyst removal, laparoscopic or open. And all of the intrauterine procedures women take, like curettage, like HPV-related or other injuries to cervical canal, myomectomies, cysts removal, I've said, and polyp removal. So those are all things I see with my infertility clients, and those are all those are all risk factors for adhesions. Every time I see this with patients, I consider adhesions. And my personal story. So this is Mila Rebecca, my 2-year-old baby girl. She was born via urgent C-section. My CRP was at that point around 200. I have left with hypertrophic scar. I never before experienced, but postpartal, my intercourses were extremely painful, like something is inside and bothering. Painful, and my hip has become painful, and I couldn't walk properly. I couldn't lift my leg without the help of my hand just pulling up for my pants. And at some point I experienced amenorrhea. So I got, as mentioned, I'm tracking my menstrual cycle with symptothermal method, that is actually tracking the cervical mucus and measuring body temperature to confirm that ovulation happened. And I saw clear ovulation signs. So I had ovulation first time after giving birth. And I was expecting my period to come within next 10, 12 days, latest 14, but it didn't come. Everything, all of my signs that I was familiar with from my body, that the period is coming, they were present, like it's gonna come every minute, but it didn't came. Instead, exactly 1 month later, ovulation signs again. Like the normal cycle happened, but no bleeding. I immediately knew what's going on. I started fibrinolytic therapy, but as I was breastfeeding, I couldn't take the high dose, I was afraid, and so on. But when that happened for 4 months, ovulation comes, no period. Ovulation comes, no period. I just said, okay, baby, it's just, mommy has to be okay. I'm risking this. Although I have later found that lumbrokinase is actually pretty safe in pregnancy and while breastfeeding. So I took the full dose. It took me 6 capsules of lumbrokinase for my body to bleed. In 10 days of taking full dose of lumbrokinase, I could normally walk. I could normally bring my leg up. I must say, I was breastfeeding, and I was from the birth in the rehabilitation program, so I was working out. I had a therapist to work on my hip mobility and my strength. So it's not like muscle tonus was low, or it's not like it was breastfeeding. There was something else, and this personal story got me to think harder. You know, it was that intrinsic motivator to change, to understand better. So I knew it was tissue injury, C-section. I knew it was inflammation. I wasn't sleeping, and I know from my clients that is the case. But could it also be something else? Why do some women form adhesions? I know women with C-section and they did not have the Asherman syndrome, what is basically when after the C-section, the adhesions formed abnormally in my uterus and completely closed it. So the endometrium was shedding and bleeding, but bleeding inside, so it could not pass out. And that is one of the risk factors for developing endometriosis. If I had not known this knowledge, I could have endometriosis by now. Genetics. I was like, one evening I was working after I put the baby to sleep. Could it be genetics? And I just typed to PubMed, genetics and adhesions, and I really indeed got some studies. And as we see, it is a complex process. And if we have some enzymes here in this process, then we have to consider genetics, because if we have SNPs mutations, those enzymes will be coded differently and they will run slower or faster. And this is what I have found. Studies are not so completely confirmative. It is a new area being researched, but it has so much sense. And I will show you with my clients that it has sense. So if the fibrinolytic activity, endogenous fibrinolytic activity, gets lower for many things, for this pi-1 genetic polymorphism, because of the oxidative stress, because of the inflammation, we do see the abnormal adhesion development. These are here only short the studies I have found what could have what could influence the abnormal adhesion formation. So pi-1 plasmin activator inhibitor 1. If we have 4G/5G genotype, it is more likely for a woman that is inflamed to form abnormal adhesion. Serotonin, abnormal serotonin also, several studies, and methylation is a big one. If we have a poor methylation, it comes together with chronic inflammation, and that is what I see in practice, is that those factors bring us to more dense and more firm and a bigger amount of adhesions, bringing us to bigger complications, more severe complications regard to infertility. So this one study is so interesting because it showed us that patients taking statins at the time of having abdominal surgery have formed less adhesions and have had less adhesion complications post-surgery. And what we know is that endometriosis and adenomyosis is highly inflammatory condition, dependent on estrogen, that these women have impaired immunity, impaired detoxification, they're estrogen dominant, and this is what we need to consider, and this is what gets passed over and somehow skipped in the management of women with endometriosis. Some therapists do give antioxidants and anti-inflammatory omegas, but it is subdosed. So my mission is just to do everything we can, not only I, but we together, in optimizing nutritional status, to optimize fertility, to minimize inflammation, maximize adhesiolysis, and improve fertility without invasive techniques. What we have with my clients is that they have a poor nutrition, poor lifestyle. Oh, I was just working a lot and eating whatever came to my hands. eating and walking, you know, or eating in front of my computer. And what we then see is inflammation, of course, not in a year, but within 20 years, we see endometriosis forming, cysts, fibroids, and pregnancy loss. So basically, all those women are labeled as normal until the time of trying to conceive comes, and they come across the problems of not being able to conceive. Then we see endometriosis, then we see cysts, then we see polycystic ovary syndrome, and pregnancy loss. So what did they do? They take either oral hormonal contraceptives or get that surgically removed. Then we get the adhesions. And if we haven't do anything about poor nutrition and lifestyle, we go around. And it just gets worse and worse. And the women only hear, oh, it's just tubes, just get them out. We have IVF, you can conceive that way. Oh, we just need to open one more time, no big deal, it's just surgery, you know, we're good at it. Oh, just freeze your eggs and wait for better time, no worries. You can't walk? I'm sorry, not OBGYN's fault. So this is what I was told. Painful sex, just relax, bottle of wine and it'll be fine. So painful ovulation, painful intercourse, painful urination, defecation, painful breathing, painful walking and talking because nobody is listening. This is a struggle and it gives me always a cry when I think about it. I'm going to present 5 cases from my practice right now for you to see and get the feeling what can be done. So 39-year-old woman from Croatia, she had severe immunity impair and energy going down after apparent mononucleosis, so it wasn't confirmed. She had immunity crash and she went to doctors and they have found endometrioma on the left ovary. It was left intact because she did not want to go to surgery. She wanted to try something for herself. She has a medical background. She gets treated with oral hormonal contraceptives that suppresses the estrogen and the cysts goes away within 5 months, but comes back in 2019 because she didn't change anything else. At that time, Hashimoto thyroiditis gets diagnosed. She's of course bloated, tired constantly, and she's at that moment 2 years trying to conceive. Had 1 insemination, hydrosalpinx, so the adhesions have blocked the fallopian tubes, and within that blockage of adhesions, water was filling up, and that is what we can see on ultrasound, that robbed water, or yeah. So she self-administered serapeptase for 2 months, 1 time this bigger dose. At the moment when she came to me, I said, okay, finish the serapeptidase, but take 2 times 250,000 units. We added gut repair protocol, so we added glutathione, omegas high dose, checked for PI and MTHFR, and then after finishing with serapeptidase, I introduced full dose of lumbrokinase, 3 times 2 caps for 3 months. She came negative to PI and MTHFR, so no genetic factor. She did not have previous abdominal or uterine procedures, surgeries. She was only inflamed. Within 3 months from the protocol, hydrosalpinx was gone. Ultrasound showed no hydrosalpinx. She was not bloated, she had energy, but no baby was there, and she was inpatient. And she had the opportunity to go to surgery in France. The surgeon found her abdomen full of adhesions. Cleared them obviously out, and she's now taking lumbrokinase and hopefully waiting for a baby to come. Also taking all other measures anti-inflammatory. This other client, in contrast to the former did not have a severe clinical picture of endometriosis. So she had, her periods wasn't painful, her ovulation wasn't painful. It's just that she had cysts that could be seen in ultrasound. And that was moving bigger or smaller or vanishing. This client had a severe clinical picture of severe endometriosis. She had, since the beginning of menstruating, had painful periods, painful ovulation, painful urination, painful defecation, digestion problems, impaired immunity, was constantly sick. She had long time using oral hormonal contraceptives to suppress endometriosis and to suppress estrogen dominance. But that only added up to her nutrient depletion. As we know, the birth control pills deplete B vitamins, magnesium, and so on. She is, since she knows for herself, anemic. Also her mother and all her family line, and she was very inflamed, what Dr. Greenfeld talked about yesterday. She had difficulties planning, calculating, reading. It was just missing words. And her history of surgeries was 2008, one surgery, and again, big one in 2018. So 8-hour robotic surgery, you get the picture. She was clear and they found adenomyosis, but they did not touch that. Endometriosis is when lesions of or tissue similar to those of that of endometrium gets found outside of the uterus. So we can find endometriosis or endometrium-like tissue on ovary, on fallopian tubes, anywhere in abdominal cavity, on diaphragm, in the brain. It's really complex condition. And adenomyosis is seeing those endometrial tissue in muscle layer of the uterus of the myometrium. This lady was 6 years trying to conceive. In the moment she came to see me, we introduced gut repair anti-inflammatory protocol, lumbrokinase, mitochondrial support, nutrient correction. She gets instructed to check OGTT and genetics, but she till today did not do that because she's working with another practitioner and it's like jumping from me to him. And after 3 months, after taking double dose of DPP-4's digestive enzymes with main meals, she and other gut repair stuff, she improved, her digestion improved. She wasn't constipated no more. She was less bloated, and her immunity was good. She wasn't sick since. Then she goes off to that another doctor. He introduces heavy antibiotic therapy against Fusobacterium. That is, so if we see Fusobacterium and chronic Escherichia coli with symptoms of menstrual cycle like painful periods, painful ovulation, inflammatory markers, then we have to consider endometriosis. So unfortunately, she did not react good to these antibiotics. That sets us completely back to bloating and pain. We are now repeating the protocol and waiting how she will react. Those are both of my newer patients after my maternity leave, so I don't have them for a long time. But I have seen some great results in such short periods of time, so 3 to 6 months. This one, I did not have one-on-one with her, only mail consultations. 40-year-old having several pregnancy losses, and on her, and several curettages, on her asking, she insisted on hysteroscopy, and that is when Asherman syndrome was confirmed and diagnosed. She had 3 hysteroscopies only to clean out the adhesions. At that point, she comes to me, but at that point, I'm not aware of lumbrokinase, because that was before my personal story. I knew for lumbrokinase, but I did not knew it was that powerful, you know. And I gave her only strong anti-inflammatory protocol. She got pregnant after 6 months, and the pregnancy got to the 2nd trimester, but she lost it again. 5th hysteroscopy was done, and adhesions were present again in huge amount. She has genetic factor, and now is the question, if I come to introduce lumbrokinase to her now, will she have the will and the energy to try again, because after all of this, she is emotionally and financially exhausted. This client is with me before my pregnancy, so almost 3 years. She's 35 years old. At that point, 5 years trying to conceive. Also male infertility factor, but we corrected that easily. Later on, they detected prolactinoma. She's natural conception girl only, taking metformin to correct her insulin resistance after we found abnormal glycemia. And she had several surgeries. So she had tissue trauma. She also has a genetic factor. Her interesting is that at the time she came to see me, she already had managed alone to unblock those tubes. Both of her tubes were completely blocked, and she used for 6 months full dose on her own serapeptidase and wobenzym with castor oil packs every day for 1 hour, and she managed to unblock the tubes. This is the case where this is not medically, so not a person with medical background. It's a common person, just devastated and desperate because she could not find any help, and no one actually believed her that her tubes are open. The doctor, when they repeated the ultrasound, could not believe, told some kind of a miracle. We introduced anti-inflammatory protocol and gave her, of course, nutrients to correct nutrient depletion, gave lumbrokinase, but the thing is, she would only take those supplements in follicular phase until ovulation, because she desperately wanted to try every single month. And she was afraid to take so many supplements after ovulation. So what if pregnancy happens? I have tried so much and so long till now. If it happens, I don't want to mess it up with so many supplements that I don't know what they are. So we had a short window, but again, we did something. We get her pregnant 3 times. Unfortunately, it wouldn't develop. She lost all of 3. And now she works with Dr. Boyle from Ireland, and we are waiting for her surgery in Croatia. She decided to take the surgery, and then she's taking lumbrokinase now and prepared to take it afterwards. And this is one client from Berlin, actually. Interesting story. I think it might have happened that after long term of no activity from her uterus, she might have developed Asherman syndrome and adhesion problems. And I did find a study showing that after long-term IUD use, there is a bigger chance and bigger risk of intrauterine adhesions forming. What we see here is, if you read this one here, the presence of Asherman's syndrome in a 52-year-old virgin menopausal woman without any significant predisposing factors, illustrating the possibility of having intrauterine adhesions without a known cause. So we do see that there are women out there having adhesions with no previous tissue trauma from surgery, with no genetical factors, but inflammation. And this is what all of those people are actually, and therapists are missing, and I'm practically pretty angry why this gets missed and not done. So I'm gonna share my protocol with you, just looking my time. What I do first for everybody is I check glycemia. I check glucose, I check fasting insulin. If possible, we do the OGTT. If possible, we do the glucose profile with just glucose monitor 7 times a day. So in the morning, 1 hour after the breakfast, 2 hours after breakfast, 1 hour after lunch, 2 hours after lunch, and then dinner, or continuous glucose monitoring. We, of course, have to correct nutrient deficiencies. First of all, iron, because it takes time. I add magnesium immediately. I check D vitamin and B vitamins. I address estrogen metabolism, so a lot of fibers, a lot of antioxidants, anti-inflammatory diet, so a lot of veggies, a lot of seeds and nuts, enough protein, and balance the meals. So not like eating all the time, but having them on a 3-meal regime, and most of them work very, very good on a 3-meal regime. They do have a window of decent fasting, although when patients are so long anemic and exhausted, I do not force the fasting, long fasting. I think it's just another stress. Gut health is a big one. So introducing gut repair protocol, and I mean, you can't really separate these 3 things or everything. It's just, it comes simultaneously. Everything I do, I will show you on the example of endometriosis. And then, of course, there is this fibrinolytic activity of lumbrokinase and serrapeptidase. If I see more mucus in the nose, often running nose, and that upper respiratory tract issues, I go with serrapeptidase first, because it is really important to me that they can breathe. That is like number 1. So when I have the woman with endometriosis, we see what we can do with digestion. We correct gut permeability, so L-glutamine, zinc, gut microbiota, proper probiotics, postbiotics, butyrate. I correct or add support to vaginal microbiota, and especially I would like to highlight these 3 strains, Lactobacillus crispatus, Jansseni, and Gazeri. They do the work. Basically, everything else just corrects temporarily. These guys do the work. Biofilm disrupting formulas, because we see a lot of Escherichia coli, we see a lot of Candida, we see a lot of Fusobacterium, and it can be disrupted with, again, serrapeptidase and other phytochemicals, and transfer factors to correct the immune response, liposomal glutathione also for that, and this estrogen metabolism. Omegas, I don't go lower than 4 grams of EPA and DHA because it's just not working. They need higher doses. Lumbrokinase full dose, and I work with Bolioke lumbrokinase as most effective, and it is best researched. I do magnesium glycinate if they have strong neuroinflammation symptoms, threonate. And then I check what is with histamine, I check what is with methylation, mitochondria, HPA axis, and nutrient deficiencies, of course. Sometimes when there's everything to handle, I handle gut, I handle glycemia, and then take Bolioke because it takes time. What is problem with those patients of mine, and what challenges me in practice is, first of all, the trust. Why no doctor had said this to me till now? Why haven't I read about this anywhere? Are you sure this is it? And then time. They don't have time. IVF clinics are just putting so much pressure. No, we have to do it fast. You have to go from one IVF cycle to another IVF cycle. No time. You're getting to menopause, no time. And actually, from a cycle to cycle, they only get more exhausted. And if they gave themselves 3 months window for anti-inflammatory protocol to get that antioxidants to improve egg quality and sperm quality, they would get time. But it is they are impatient also. Compliance, many capsules. We have to talk about this, as I've heard from Dr. Greenland. You have found a way. Many capsules and taking everything, it's just heavy, and the price, of course. They are emotionally exhausted and financially exhausted. I think we need to start sooner. We need to start much sooner with teen girls. If we see early signs of endometriosis, we can do so much to prevent those multiple surgeries and that estrogen dominance to get out of control. We should never stop asking ourselves questions, because there is always something else that we haven't taken in mind, and then always something else comes up. And with every new client, we learn a new thing. We should be louder and presenting and discussing such cases like here today more often, and because if we are not loud, then people that do not know the work will outloud us. And be present in the community. Unfortunately, it may sound funny, but if they told me 10 years ago when I was working in Clinical University Hospital that I will be on Instagram and educating people on Instagram, I would say you're mad. But the thing is, these women that have lost their trust in the health system, they are searching for answers on Instagram. And if the experts are not on Instagram, then you know who they will find: misinformation. And if we see that is from the numbers from that consensus on adhesions. So if 66 to 95% of people form adhesions, why is that not a part of informed consent? It should be ASAP introduced into informed consent. I have found studies that in Germany that is a case in some hospitals. In Croatia, unfortunately not. I don't know how is it in other countries. Up to 60% of surgeries are repeated ones. If a surgery is not urgent, Why don't we take 3 months? We can move mountains in 3 months. In 6 months, you probably won't even be needing the surgery. But let's introduce that first. And if so many adhesion complications are present, why don't we do post-surgery fibrinolytic enzyme protocol? And why don't we tell people implement anti-inflammatory lifestyle? That is basically it from me. I hope you found it interesting, and I hope you will get back, and then that we can together move mountains.
Thank you. Vielen Dank, Maya, für die tolle Präsentation. Jeder sollte Biofilm-Breaker bekommen. Das ist ziemlich klar. Not just in the gut, it's for the whole.
Nice too, so it's nice to hear about it. Just curious if you could elaborate a little bit on, you mentioned Fusobacterium and E. coli and how that relates to inflammation and chronic pain in the pelvic area. Can you just elaborate on that a little bit? I'd love to hear.
I just think those women are so, they have impaired immune response, and they're just susceptible to chronic infections and pathogens like that. It's not like they have been infected and the pathogen has made a problem. I think it's other way around. It's just impaired and depleted completely. So all protective mechanisms get depleted if you're long-term estrogen dominant, if your detoxification is not working, if you're inflamed. So obviously we are surrounded with different pathogens and we get in touch, but such a person can handle it. And then if they get in and get wild, of course we then have a problem, and that adds up to inflammation and get us in that vicious cycle, and exaggerates the pain also, and ruins the quality of life completely.
Thank you very much, Maya. Clap your hands, please, for a great presentation. Thank you. 2 Ankündigungen noch ganz kurz. Ja, die Buchautorin, Frau Dr. Hopf-Seidel, und der Buchautor Hans-Peter Gabel, ihr seid dann draußen für die Signatur eurer tollen Bücher. Und wir haben auch noch Workshops, soll ich euch noch sagen, die auch oben stattfinden. Momentan ist Dietrich Klinghardt so noch am Reden. Und eine gute Frühstückspause. You're welcome. Konferenz of Friends. Coming back again. Thank you.
Good morning. Just a few announcements before we begin. First of all, if you'd like your CME points, then please go to the reception and ask them about that. And for example, Dr. Greenland, they're able to do that for us in the UK as well, to issue something, you know, evidencing all the points here. Another thing is that unfortunately Catherine Kirk was too ill to attend in person, so she recorded her presentation. We had said originally that there wouldn't be any video recordings, but Marcus and Dr. Armin felt this was important really, because in a way that's what we as therapists and doctors are doing, is supporting patients however long their illness continues, and hers has been very, very long. But this emphasizes how important it is to just stay with the patient, not throw up your hands in the air and say, well, there's nothing I can do, because there is always incremental improvement. There are always further things you can do. There are developments in medicine, aren't there, that you can continue to apply. So please don't be irritated by the fact that it's a recording. She's done a wonderful job. She actually, while ill, did it yesterday. And it will only be 42 minutes long. So right after that, Dr. Carla Malsetti will come. So there won't be a big long pause before the next one. And if anybody's interested in going to Dr. Paul de Zadeler's workshop, that is actually going to be ready just at the end of this one. So I think you can go to that one at 11. You'll be able to catch that if that's something you're interested in. So just to introduce Catherine Kirk, despite the challenge of living with chronic systemic illness for over a decade, including being bedbound for the last 5 years, Catherine Kirk has created and built a successful remote consulting business on word of mouth alone. Today she is highly sought after as a leadership effectiveness coach in the fast-paced world of technology. And she is now most known for a radically different leadership approach that she has developed that empowers leaders and their teams in tough, impossible circumstances to achieve success that lasts. So that's very encouraging as well. Just to mention that for technical reasons, because this is a recording, immediate sort of interpretation won't be available, but we're very much hoping that everybody will understand sufficient English to get what she says in the recording. So thank you very much.
Hi, my name is Catherine Kirk, and I'm here to talk about how to stay motivated and innovative in constant adversity. Before I start, I wanted to dedicate
can I introduce her now? Thank you. So this is Dr. Carla Marsetti. I'll just introduce her briefly. She will be starting now a little bit earlier than arranged, and that just simply means that you'll be able to go off to your lunch break a bit earlier, have a bit more time to look at the industry exhibits and all the rest of it. So thank you very much, Dr. Carla Marsetti, for being flexible. Dr. Marsetti has earned her master's degree in biological sciences at the University of Bologna in 1979. She's always been an active part of avant-garde scientific research in the fields of microbiology and intestinal microbiota, with multi-year collaborations with universities and pharmaceutical companies. She has developed new, very detailed diagnostic tests concerning intestinal bacterial flora and low-grade inflammation. She's also deepened the technique of dark field microscopy using new nanotechnology systems, and she'll be introducing her metabolomics tests and others to us now. She's currently the scientific director of the Val Zambro Laboratory of Bologna and is engaged in other related activities. So over to you, Dr. Marsetti. Thank you very much.
Good morning, and thank you for the invitation to this conference. My topics deal with the phenomenon of dysbiosis and how to study in light of new diagnostic discoveries. In recent years, the intestine has assumed fundamental importance in the health. It has linked to all our organs, immune system, cardiovascular system, nervous system, metabolism, and so on. And this interrelationship occurs through a change of signal molecules which can be either cytokine or metabolized. This is why, by checking them, I can obtain important information and consequently carry out target intervention and treatment and therapy. We represent the microbiota at the root of a tree in whose branches we found the connection between it and all the organs. So with a treatment, gut microbiota to have effect on, for example, endocrinal balance, intestine diseases, hypertension, diabetes, obesity, and so on. All the diseases, and important of chronic diseases. And it meant that by acting on the microbiota, I carry out systemic action and treat many diseases. In our body, we are 1 trillion cells, and we have 100 trillion bacteria. So the bacterium of our body, in our body, make the lion's share. So we have to work with them to have to make an action of our health. But what is dysbiosis? Dysbiosis is a very popular word, but is a term now used but does it really mean? If I have an eubiosis, I have a mucosal integrity first, is very important. I have not inflammation. I am a tolerance with allergen, with bacterium, and a good immune system. But when I have dysbiosis, I have inflammation, leaky gut, and begin the problem. So, dysbiosis means microbial imbalance inside of the body, a loss of beneficial bacterial, overgrowth of potentially pathogens, loss of overall diversity. So, dysbiosis have been involved with every pathology till now. But we have said how important intestinal health is, which determines general health. And that is important to understand that not only the microbiota, but the entire intestine plays a fundamental role. Therefore, we need a complete diagnostic that sees all these aspects together to have a complete dynamic picture. So, we have to change microbiota, check flora with screening microbiota. We can check inflammation with some tests, calprotectin, lactoferrin, M2PK, cytokine, etc. And we have to check mucosa for permeability, because we have low-grade inflammation, permeability, and the passage in the bacterium or fungi in the bloodstream. And so we have checked donulin, secretory IgA, histamine. And the last but not the least, we can check metabolites. Is very, very important. Metabolites we can check with metabolomics and lipidomics. All the branches of the science that hand with omics are omics science. Metabolomics, lipidomics, genomics, transcriptomics, and so. And these are the new science, the science of the future. And so they permit to have a multi-omic approach. So you can use genomics, you can use metabolomics, you can use microbiomics. And metabolomics is the total repertoire of small molecules present in the cell, in the tissue, in the organ, and in biological fluid. So small molecule like sugar, lipids, small peptides, vitamin, amino acid, and so on. All this I can check in the body, and I can check the result in the action in the cells. And so we pass from the gene with genomic, this pass through mRNA transcriptomic, to pass to protein and membrane, make proteins, what proteomics, and proteomics make metabolites. So when I found metabolomic with metabolomic, I can have a dynamic picture of the cell. So from genomics to metabolomics. In fact, the genomics is to be able to do the prospect, the possibility, but not the real, okay? And the transcriptome is to start, the proteome is to do, but metabolome is to be. And to be means that I have a dynamic picture in this moment of this patient. It's very, very important, because all the effects of the all action of disease, of co-infection, infection, toxics, and so on, all the things we have reverse and the way is in metabolomic. Metabolomic can see all things. And what is mean that in Fishman that and can catch one fish instead of the net of the other fishermen that can see catch all the fish. Metabolomics is the new clinical biochemistry. It's a technology that identifies discriminal biomarkers in early diagnosis of different pathologies, anticipate the outcome and evaluate and monitors therapeutic effects. I have a lot of the data, in the net of data that I can understand the truth of the cells. So, 7,100 papers on metabolomics on PubMed. 1 out of 10 technologies that will change the world. And €1 out of 18 spent in medicine was devoted to metabolomics. So metabolomics grow in the future and is a very important market and revolution from evolution to revolution. In fact, we have a lot of publication in the animal, in the child, in the adult, in a lot of pathology, respiratory disease, cardiovascular, renal, sepsis, nutritional, and long-term diseases and cancer, and sportomic, for example. And so, what species identification, what? The matrix is all the matrix in stool, in urine, in swab, in exudate, in tissue, every cell I can investigate. And I want to detect bacteria, fungi, virus, and parasites. But to have exact picture of the real situation, we must identify them with PCR, but PCR does not tell us if these microorganisms are alive or dead. And if a microorganism is dead, is not very interesting to be a trigger of a pathology. And with genetic analysis till now, make with 16S sequences, PCR sequences, are not correct because we can see all the bacterium live and dead. And so we must return to the microbiology and use both microbiology and PCR test and control the life, the vitality, the potential activity on this species with specific culture. And then culture give us the possibility of testing target therapies. So with necessary both the technique, old technique and new technique. We can check bacteria, fungi, parasites, virus, and so on. And what important that when there are a lot of bacterium of fungus, the bacterium and the fungus form a biofilm. And biofilm is very important. Very often we cannot see many pathogens in the stool sample because the biofilm phenomenon has occurred. So if I can check in the stool and I found bacterium, or I don't found but the bacterial is. So I need another techniques to understand if there is these pathogens, because pathogen can make together bacterium and fungus and viruses biofilms. Sometimes the bacterium on the fungus entered in bloodstream. And we can see it in dark field microscope. Dark field microscope can see all that pass through the bloodstream and take a picture. For example, another teacher has explained with form, roll body form that what in the Borrelia, for example, cell wall deficit form of bacterium, not only Borrelia. Even bacterium has wall deficit form. And this technique is the unique technique that see all we pass in the bloodstream. That I see this in the blood. I have permeability. I have permeability in the gut. I have permeability in each mucosas, each membranes. And leaky gut, bacterium, fungal, parasite, crystal, atopobiosis, inflammation, oxidative stress, I can see with these techniques. But I want to introduce the atopobiosis, the term atopobiosis. I would like a concept called phenomenon of atopobiosis, that is a bacterium that is in a region and is not pathogenic, which, through the permeability of the mucous membranes, migrates to another district, which is not its own, and therefore becomes pathogenic there. Let's take an example of E. coli, which is fine if it grows in the intestine, but if it passes through the walls and goes on the genitourinaris, for example, district, is caused cystitis, vaginitis, which are difficult to eradicate for permeability. So we have the techniques and the equipment for make omics. We need a spectrometer, immunochemistry, real-time PCR, gas mass spectrometry, liquid mass spectrometry, and at last ECP spectrometry. Some example of the use of metabolics to study the gut health. We have a non-invasive sample because we need only the urine. And from urine, I have a lot of information. Why I use urine? Because metabolites, for example, organic acids, are 100 times more present in urine than in other liquids. So you can use urine. And this is a case report that I can check all the metabolites of fungal and bacterium overgrowth. For example, citramelic acid, 5-hydroxymethyl 2-furan carboxyl, tartaric acid, furan carbonyl glycine, tricabelic, arabinose, arabinitol, furan 2,5-dicarboxyl, and 2-hydroxyglutaric. All these are metabolites of fungus. And fungus, they are divided in yeast, example Candida, Saccharomyces, or mold, Aspergillus or Penicillus, and not mushroom. Mushroom is edible fungus. And we have metabolites. This is group of metabolites of the yeast, of the Candida, like arabinose, arabinitol, mold, Aspergillus, with all these metabolites. Why Candida is so important? Candida produce metabolites like tartaric acid and arabinose and arabinitol. And those metabolites inhibit a step of Krebs cycle. For example, high level of tartaric acid and inhibits a step of Krebs cycle in fumarate, and from fumarate acid to malic acid. So can interfere with production of ATP in my mitochondria. And Candida and the other keep together to toxic chemical and heavy metals and oxalates and other toxins and put together to make a block of Krebs cycles. And for example, Candida metabolites are inhibitor of aconitase enzyme. For example, we can see the action of Candida on the Krebs cycle. And so arabinose and other metabolites is not only microbial metabolite, but also in Mycobacterium, and Mycobacterium includes leprosy and tuberculosis. And L-arabinose is found to be associated with ribose 5-phosphate isomerase deficiency. Okay, so very important. And another important thing is Candida contains proteolytic enzyme capable of destroying part of 2 arms of secretory IgE, which are very important because they are like a protective vortex of the intestinal mucosa, where they are much more concentrated than in other districts. So it's very important to check AGS in the stool. And for example, arabinose and arabinitol is very important. Arabinose is ground like sugar, for example, yeast, to that can leave Candida. Arabinitol is a product metabolite only produced by Candida. So when a patient has arabinose and arabinitol, the patient has invasive Candida. It's very important because it's more important that only arabinose. It's important the laboratory make arabinose and arabinitol. And Candida is important, snaky and dangerous of the body, and above all, difficult to eradicate. Candida can actively penetrate in the intestinal mucosa, like it's IFE, or it can penetrate by endocytosis. The host can produce different peptides, but these are inactivated by Candida, and then it's produced proteolytic enzyme and candida lysine, which causes the opening of digestion and allow that enter other similar pathogens. So it's very, very dangerous Candida and chronic Candida. And there's this metabolites of Aspergillus. Aspergillus is a mold. I can found the mold of the wall in the house, or respirate or heat with food, and the metabolite that can check it is 4-carbonyl glycines. And Aspergillus can make respiratory disease, allergic bronchopulmonary, allergic sinusitis, chronic pulmonary aspergillosis, aspergilloma, invasive aspergillosis. And another metabolite of aspergillus is tricarbalic acid. And fungi make mycotoxins, and mycotoxins are is inside of the food, and you can breathe if the aspergillus is on the wall or in the food. For example, in corn, in wine, in nuts, and so on. And aspergillus metabolites, tartaric acid. Again, tartaric acid is a fungal metabolite. Elevate levels in the urine may be due to the presence of mold and yeast in the digestive system or bladder. It can be produced also by Acrobacterium, Nocardi, Rhizobium, and Saccharomyces. And aspergillus is very toxic, and most prevalent mold group in the environment has caused billions of dollars in damage of crop and livestock. And aspergillus make toxin like aflatoxin, ochratoxin, pathologien, fumagalin that can check in the urine. Aspergillus toxin can be found in cereal, crops, peanuts, corn, rice, okay? But also in eggs, milk, in meat that come from animals and product from animals. And aspergillus can make a similar of citramalic acid and malic acid, so we can block again the Krebs cycle. And another metabolite is tricarbalic acid that metabolize another fungus, Fusarium, and is metabolized another fungus. And this fungus can produce fumosin, who is another mycotoxin. And it is another inhibitor of aconitase and block the Krebs cycles. So there are a lot of publication of the product of fungi, for example, psychiatric disorder and depression and problem of behavior and autism and so on. So it's very important to check if there are fungi in my body. And another test that permits to see the inflammation are the salivary cytokine. We couple lab technique by immunochemistry and genetics, but genetics are 100 times more precise than immunochemistry. We can check the salivary profile with interleukin-1 beta, interleukin-2, 6, 10, and 12, and 16, gamma interferon, TNF-alpha, and in a complete profile. And so with a lot of data, we can suggest to the doctor possible target therapy, healthy diet, candida treatment, toxin reduction, digestive health, microbiome diversity, proteolytic enzyme to release the biofilm, microencapsulate essential oil, for example. In fact, at the last of the test, we can make, instead of antibiogram, anti-aromatogram. Aromatogram in the measure of the power of the essential oil and their antimicrobial activity. with a ring of inhibition, like you can see in the slide, I can see the potential activity of each essential oils. The essential oil can block in germ metabolic function, and they can release the germ on inhibit its growth. So it is very important, because instead to use antibiotic that make sensitivity, and resistance, essential oil doesn't make it safe and are strong like antibiotic. But is necessary of a new formula patented that the essential oil are in microsome and liposome. You can take and go to that direct on the intestine, on the gut, and make their action against the pathogens. So the use biological effect of essential oil, because reducing multi-drug resistance are synergic effect with antibiotics, prevent treat side effect associated with the conventional treatment, and the historical self-record, hundreds of thousands of years of documented safety when used according to various traditional system medicine. And so conclusion, I'm finished, and thank you for your attention. And you have, if you have asked some question to me, I'm ready to understand, to answer.
Thank you very much, Dr. Marsetti. That was fascinating. Any questions at all? It was very complex biology, actually. I think we need to look at the slides again. But the connections with how Candida interrupts the Krebs cycle are indeed really stunning.
It's very important, because when the patient is tired, and brain fogs, and non-concentration, and behavior, change of behavior, is not, I can success. And we think problem, psychiatric problem, psychological problem, but sometimes it's toxic problems. We have many patients, psychiatric patients with depressions or autism, that we can fight against Candida with essential oil, some supplements, and the change immediately, 1 week.
Do you have samples of the results of your tests on your table?
Yes.
And do you also give consultations after getting the results so people can understand how to interpret them better?
One moment. Mi puoi tradurre che non ho capito?
Can she explain to people at the beginning, when therapists begin using new tests, it's always difficult to understand the therapeutic implications? Can she explain to people how to use them in German and in English?
Therefore, we start with the school for interpretation, because metabolomics is a little bit difficult to understand. So, but is very strong as the future of diagnostics. So the next year we begin with a European School of Metabolomics.
But what I meant is, if somebody does one test with you, then can they contact somebody for interpretation?
Yes. See. Absolutely, yes.
And then you will
we
explain.
have explanation. We have a questionnaire in the kit with the sample, and the doctor inside the laboratory answer with the, for the questionnaire, answer the results, answer the treatment, everything.
Oh, very good. Thank you.
Okay.
And how similar is your organic acids test to the organic acids test of Great Plains?
Yes.
Is it the same?
Yes.
Uh-huh.
Yes. Yes. And I developed my other molecules, and I both together microbiome and metabolic, because it's important. Because I have explained before that I have metabolites, but I have not in the stool, in the microbiome, or I have the pathogens in stool, but have not metabolites, or have both. There's three possibilities. One possibility, I found the pathogen in the stool, I have a local problem. If I both, I have a local problem and system problem. If I metabolize and not found in the stool, I have a systemic problem and I have biofilm. So I have very sure how to treat the patient. Because they have sure that I have biofilm, I've used biofilm disruptor and then essential oil. Okay? It's very important. Because fungal bacterium biofilm is very persistent, is chronic, and so it's very, very difficult to eradicate. Okay?
Any further questions? Yeah. Otherwise, thank you very, very much indeed. At 10:30, at 12:30, but we're a little bit earlier now, so you know, nice to have the time outside. Do visit the exhibitors again, please. Thank you. Hello, everyone. Welcome back after lunch. We're delighted to have Dr. Paul de Zadler with us today to speak about the impact of environmental toxicants. He's a doctor in pharmaceutical science and received his degree and training at the University of Louvain in 1991. He obtained his master's degree in nutritional and phytotherapeutic therapies in Louvain-la-Neuve, and his master's degree in homeopathic practice at VSU in Ghent. He's the scientific director of Nutrimed Research Nutritionals, located in the Netherlands and active all over the world. Nutrimed Research Nutritionals develops nutritional compositions based on scientific research and publications. He's also the director of a Belgian pharmaceutical and compounding lab in Lierre, close to Antwerp in Belgium. He was selected as chairperson for the first ever Belgian Lyme Committee that took place in Antwerp in 2015. And in 2016, he accepted the position of chairman of the European ILADS Committee, that's the International Lyme and Associated Diseases Symposium. So he has huge experience. And there's just one message that I was going to be given by you, I think. The slides and presentations of all the talks today, even those you haven't attended, will be uploaded to the cloud, and then you will be sent a link soon after this. So over to you, Paul. And can I just mention that I'll be holding up signs with how many minutes you have, but after those minutes have run out, you'll then have 10 minutes for questions.
Okay. Good.
So just for the calculation.
You will stop me when everything gets out of control.
Thank you.
Okay, thank you for the introduction, Gillian. Yeah, it's a pleasure, an honor to be here. I will, of course, respect the schedule, but I promise to speak not too fast to make sure that the translators can do a good job, because I imagine with all the special terms, and that's a really difficult challenge. But and thank you for all the work that you're doing during the entire conference. So my afternoon talk is a talk on environmental pollution, actually on the effects that toxicants cause on different levels, and mainly on metabolism, gut health, and immunity. Chemicals are innocent until proven guilty. Well, I actually mean that often we see no requirements to prove safety before products come to the market. And we know that, at least if I look how the situation is in Belgium, and I cannot imagine that it's different in other countries, regulations are slow in existence. We have too many agencies. We have local, federal, whatever agencies. We have too many political parties, and so actually no decisions are made, no communication, and actually the situation often is how it is. You will see in my lecture that many of the references that I used are American references, and I also refer to the great work that the medical association, the of environmental medicine, is doing in America, the ISEAI. Now, to evaluate and to control toxic levels in America, the CDC, the Centrum for Disease Control, conducts monitoring studies via the NHANS, that's the National Health and Nutrition Examination Survey, and that's also the statistics that I will use today. So basically, we're all exposed on a daily basis to lots of toxicants. So that means there is accumulation, but there's also amplification. So 1 + 1 is not necessarily 2, but is sometimes 3, 4, or more. Next to the data and the statistics that I will show you, it's a fact that we need to lower the burden. We need to lower the exposure. So lifestyle changes are actually required. Dietary management as well, and we can do something with nutritional support based on, let's say, a clinical and a detailed analysis of the data that we have. Now, okay, talking about metabolic issues, well, endocrine metabolic disruptors can affect our metabolism via different ways on different levels. Some of the toxicants are xenestrogens, like bisphenol A, other bind to hormone receptors or simply block metabolism. And the disruption often results in obesitas or diabetes. Today, according to statistics, between 24 and 34% of the population is dealing with metabolic issues, insulin resistant, cardiovascular problems, diabetes, and whatever. So we actually reached the point where we really need to include all the risk factors and also the non-traditional risk factors. And many of the pollutants actually are obesogens and diabetogens. And if I use these terms, well, obesogens are chemicals that directly or indirectly increase obesity. Diabetogens are chemicals that directly or indirectly increase diabetes. Now, it's no longer a matter of saying, okay, it's often an imbalance between the calories that you take in and the calories that you consume. There's much more going on. It's like an epidemic and a real shift where we favor more calorie storage. So let's see if we can define and deeply analyze to see what contributing factors are. And one of the main underlying mechanisms is actually the fact that different environmental toxicants, they disturb what we call the PPAR gamma pathway. Now, PPAR gamma is a master regulator of adipogenesis. And in the field of molecular biology, well, the PPARs are a group of nuclear receptor proteins. They regulate the expression of the genes. That's actually what nuclear receptors do. They bind on genes, and then they say, okay, this will be the expression. And so the PPARs participate in different physiological functions. And in the PPAR family, we actually have 3 subtypes: alpha, beta, gamma. Okay, well, let me show you probably more precisely what I mean by this. So this is PPAR, and PPAR is somehow activated first by a ligand. And of course, in our metabolism, we have different endogenous ligands, often fatty acids. So they bind on PPAR. PPAR then usually goes in interaction with other proteins to form a dimer, and then binds on the genes, on the promoter region of the genes. And that's actually where this PPAR will decide on the expression of the genes. Okay? Now, next to endogenous ligands to activate this entire system, you will see on the other graph that for PPAR gamma, we have a pretty large ligand binding pocket, and it accommodates many different chemicals, including the chemicals that we discuss here today. So they can really easily interfere with PPAR, and as a result, change finally the expression of the genes. Now, by doing this in the context of environmental pollution, as a result of the interaction with PPAR, we see larger fat cells and we see more fat cells. Hyperplasia, hypertrophy. just to show you the effect, this effect on adipogenesis is actually also what we see in some pharmaceutical drugs as a side effect. So, for example, some drugs in diabetes type 2 or even Viagra, sildenafil, partly works via the same mechanism and could also have this weight gain as a side effect. So, left side, you see how this results in more fat cells, larger fat cells. Another effect induced by this PPAR gamma mechanism is the fact that we see a disbalance between the osteoblasts and the osteoclasts. So the osteoblasts are downregulated, and as a result of the toxicity that I show you here, it's not only a matter of weight gain, but also higher risk for all kinds of fractures. Diabetogenes, bisphenol A. Bisphenol A. Sounds a bell? Bisphenol A, let me show you. We have a lot of bisphenol A around us, but in the majority of the plastics that are manufactured, bisphenol A has been added to give more rigidity. But bisphenol A is also xenestrogen, binds estrogen receptors, and we probably all are in touch every day with bisphenol A because a lot of food packaging, especially canned food, contains bisphenol A. Now, the effects of bisphenol A on mice. Mice were exposed to low levels of bisphenol A on a daily basis, and look the effects. First, we see that the mice develop insulin resistance. But next to this, we also see that the leptin receptors are damaged. And leptin is also what I briefly covered in my lecture this morning. On the other level, well, leptin is actually a molecule that is released by our fat tissue, by our adipose tissue. We release leptin, and the levels of leptin anytime correlate with our energy levels. So leptin normally binds to the leptin receptor in the hypothalamus, and that means, okay, we inhibit hunger. We inhibit hunger because we have enough energy storage, we inhibit hunger, and by doing that, leptin counteracts the effect of other molecules that could cause hunger, like neuropeptide I released in intestines, or some endocannabinoids. Okay, now, when leptin hits the receptor, it's not only inhibiting hunger, but it also promotes melanocyte-stimulating hormone, and that's responsible for saturation. I'm not hungry, and I'm satisfied. I don't need any food. MSH also regulates pigmentation and the release of melatonin to make sure that you sleep well. Now, if I'm saying that bisphenol A, which we are all exposed to, if it's damaging the leptin receptor, well, leptin can't inhibit hunger, can't promote saturation via MSH, so we are extremely hungry all the time and we gain weight. That's the mechanism how bisphenol A is causing weight gain, but also diabetes as an environmental problem. And I'm sure that this is a part of the medical field that we normally not immediately take into account if we have complicated cases. Other diabetogenes, pesticides, phthalates, arsenic. Studies, data show exposed to arsenic, we have 5-fold higher risk to develop diabetes type 2. Now, more data, PCBs and the Anniston Community Health Survey. Anniston, small city in Alabama, is a city with a a lot of history of heavy metal production and chemical manufacturing, and there was actually a Monsanto facility between 1929 and 1971. And as a result of environmental pollution, well, the residents in Alabama were exposed to high levels of PCBs. Environmental contamination and health concerns led to many different court cases. The residents in Aniston had 2 or 3 times higher levels of PCB than compared elsewhere. Okay, and this Aniston Community Health Survey is an ongoing study to reveal and to show the effects of PCBs on human health. And the first marker is, marker for insulin resistance, HOMA-IR. It's a validated marker. It tells you how much insulin your pancreas needs to produce to control your blood sugar levels. It's calculated based on fasting glucose and fasting insulin. And in a general way, we expect that HOMA-IR index, if it's 1, it's okay, you're insulin sensitive. If it's more than 1.9, it's getting problematic. More than 2.9, it's real severe insulin resistance. But in this ongoing study, measuring the effects of the Monsanto factory and the PCBs on health, well, another marker, insulin marker is used, and it's HOMA-B. And HOMA-B indicates how your B cell dysfunction is. A lower HOMA-B indicates more B cell dysfunction. Now, what we see here in Aniston is a combination of lowered insulin production, more insulin resistance, but also liver injury. Some of the data, if you see this data here, and you're probably surprised that, how come I never heard of this before? There's patients living in that specific area, liver disease prevalence 60%, obesity more than 50%, diabetes 27%. And like always, court cases, Monsanto washes off their hands like with Roundup. Oh, we don't know why, it's coincidence. Now, focusing on liver injury. The toxicant-associated fatty liver disease closely resembles to alcohol liver disease. In both, we see a correlation with diabetes type 2, insulin resistance, metabolic syndrome. We also have a more severe form, the toxicant-associated steatohepatitis, what actually means that the liver can't break down fats, fats accumulate, hepatocytes are filled with fat. Now, toxicant-associated fatty liver disease, alcohol liver disease. We also have another one, the non-alcohol fatty liver disease, nothing with toxicants or with alcohol, but purely with too much sugar, sweets, whatever, poor diet. But in all these liver injuries, what they have in common is actually the underlying mitochondrial damage. And to show you how they affect our mitochondria, I first will tell you in an understandable, brief way how mitochondria work, our energy factories on cellular level responsible for ATP, our metabolic energy. Well, in mitochondria, carbohydrates and fats are the fuels, and they are actually oxidized, they're broken down, and the energy in the carbohydrates and fats is captured by cofactors, NAD and FAD, and they actually deliver this energy under the form of electrons to the electron transport chain. Okay, the electron transport chain is a chain of 5 complexes doing electron transfers, starting in complex 1 to complex 2 to complex 5 finally. And at the end of the row, because simultaneously protons are pumped out, at the end of the row, ATP is formed. In this process, with electron transfers, there is always a leakage of electrons, of oxidants. And this leakage is not so important normally, it's not more than 2%. Good. Now, our own endogenous antioxidant systems like glutathione, catalase, superoxide dismutase are in charge. They need to neutralize this leakage of electrons. And if they neutralize the leakage of electrons, it's good. We don't have harm, we don't have damage to our mitochondria. Now, in this specific situation, where we try to understand what the causes of liver damage, well, we see the liver can't process, can't break down the fats. So we have more input of fatty acids and automatically more electrons to the electron transport chain, and finally more leakage than the 2% that we just showed you. So finally, more leakage of electrons. Our own antioxidant systems like glutathione are overwhelmed. And finally, we have mitochondrial damage and a loss in ATP synthesis. So if at some point in my final conclusions, if I will show you that the lipid replacement therapy makes sense here, it's not because lipid replacement therapy is a detoxifier. No, it's because the lipid replacement therapy can limit the damage induced by toxicity. Data, more data. You know, there's so much literature available. It's strange that we hardly see it, but many studies showing, okay, patients with liver injury, and we measure high levels of toxicants, heavy metals, but also some drugs in cancer therapy like methotrexate, 5-fluorouracil or tamoxifen could be responsible, or even conventional drugs like tildium or amiodarone. More data show that actually on the level of liver injuries, the PCBs and the dioxins are the most dangerous ones. What are the measurable effects of liver toxicity? How do you see it in your lab tests? Well, you see that the liver enzymes are elevated. You see that the ratio of triglycerides on HDL is higher. You see that the antioxidant systems are overwhelmed. But you also see that the ratio between reduced and oxidized glutathione is lowered. Availability of glutathione is low. And any situation that is increasing intestinal permeability is worsening this entire condition. Level 2, the effects of toxicants on gut. Toxicants alter the microbiome composition, but also they reduce the diversity. Data, good data, showing that probiotics can actually protect. They limit the uptake, the intestinal uptake of toxicants. And we see in the first publication, exposure to bisphenol A, more bisphenol A excreted via faeces if we use probiotics. Second study, exposure to lead and mercury, probiotics means less damage to the tight junctions, more fecal extraction. But also this, in my eyes, great study, mice exposed to arsenic. First, the mice are treated with antibiotics. You know, if you treat with antibiotics, you harm your microbiome. And we see that after the antibiotics, they absorb more arsenic in tissues. But if then you introduce the probiotics, you see that the levels of arsenic in tissues lower again. So there's really a good place in our analysis to promote the use of probiotics really as some kind of protection. Other studies have identified more specifically what microbiota are affected by toxicity. And we see in number 1, the Faecalibacterium prausnitzii. And the Faecalibacterium prausnitzii, colon bacteria, are actually responsible for the synthesis of our short-chain fatty acids. Butyrate, so important in immune modulation, but also contribution to to normal gut permeability. So, yeah, one more idea, the use of supplemental bioavailable butyrate makes sense. More studies showing the effects of PFOS on our microbiome. But okay, we reach level 3, the effects of toxicants on immunity, more autoimmunity. And yeah, Fasano many years ago showed us in his work, in his great work, that dysbiosis and increased gut permeability, usually they precede the development of autoimmunity. So in a modern way, treating autoimmunity is really focusing on all the different triggers that contribute to inflammation. That's a modern approach. And yes, gut and gut balance are important to control inflammation, but also sleep. If you want to treat autoimmunity, make sure that your patient sleeps. Poor sleep means high levels of cytokines and, yeah, more inflammation. Diet, but also control blood sugar levels. Fluctuating blood sugar levels means activation of NF-kappa B, means more inflammation. It's impossible to treat autoimmunity or neuroinflammation or neurodegeneration if you can't control your blood sugar levels. But also stress and pollution. Pollution is really one of the markers that we really need to include in our approach. Bisphenol A. How does bisphenol A contribute to more autoimmunity? I showed you already that bisphenol A was damaging the leptin receptors, was responsible for insulin resistance. And I also showed you, you see the can, tomato soup, yeah, that packaging often contains bisphenol A. No, actually, bisphenol A is detoxified in 6 hours. Great, but still we all have remaining levels of bisphenol A because we are more exposed than what we can eliminate. And bisphenol A contributes to more cases of autoimmunity, what we see more and more every day, because bisphenol A is responsible for abnormal liver function tests. It's disrupting phase 1 and phase 2 in detoxification, disrupting cytochrome enzymes, and finally is causing an imbalance between innate and adaptive immunity. So the direct relation between exposure to bisphenol A and more Hashimoto's, arthritis, diabetes, and so on. How is mercury causing autoimmunity? Well, studies show exposure to mercury is increasing your thyroglobulin antibodies and your inflammatory cytokines. But in a general way, all the halogenated chemicals, and we have a lot of halogenated chemicals around us, they interfere with the uptake of iodide, and automatically they are responsible for a higher risk in development of autoimmunity. More toxins, metotoxins, perchlorate, halogenated chemicals, interfere with iodine uptake, more autoimmunity. Where do we use perchlorate? Well, perchlorate is often used in what we call pyrotechnics, when production of explosives, fireworks, even rocket fuel. But perchlorate is also added to plastics to package because it's decreasing it's controlling the static electricity, what is actually an imbalance between charges, electrical charges. Phthalates make plastics, make package more durable, but also make your perfumes, your scent last longer. But phthalates are also in the IV bags that we use, and automatically phthalates leak into the content. And yeah, it's measured. Usually we find the D form, but it's metabolized to a monoform, and phthalates also need a lot of our glucuronidation. So the glucuronidation that we, for example, also need to metabolize estrogens and whatever, well, it's used here by the phthalates. Dioxins. Dioxins are generated during combustion of industrial and domestic waste. We also automatically see high levels of dioxins in populations with high fish intake, a lot of liver damage, and this strange picture. Same guy, it's Viktor Yushchenko. He was a opposition leader in Ukraine in the presidential elections, and this is Yushchenko at the start of his campaign. Nice guy, looks good. This is the same Yushchenko during his campaign. At least he was transferred to a hospital in Vienna, and then I saw that he was highly intoxicated with dioxins. So next to the environmental pollution, we see that these agents are also used sometimes as some kind of, well, it's not a warfare agent, but it's very close to. So my talk is also probably also partly getting political now, but okay, let's go back to the essence. PCBs, very, remember the Aniston Community Health Survey with the Monsanto facility? Very high persistence, more than 100 years. It's only partly excreted via sweat, stool, and breast milk, and we measure the highest levels in Ukraine, Belgium, and Luxembourg. Belgium scores very well in what I'm showing today. There's no safe level for PCBs, doesn't exist. And then PFAS. PFAS, that's a group of nearly 5,000 different compounds, and they contain also PFOS. Main chemical factory is 3M, responsible for PFAS production. And what's special about PFAS? Well, PFAS is extremely persistent. It's a chain of carbon atoms, and at least or minimum one hydrogen has been replaced by a fluorine atom. And especially this bond between carbon and fluorine is extremely strong, what explains the persistence. And so PFAS is used in all kind of packaging and to really have good resistance and durability. Now, the use of contamination via soil, via groundwater, but also partly via dust, via air. And, long time, we didn't know anything about PFAS, so the use was widespread, but there was no documentation, no publications. And now we see more and more publication. There is an urgent need to raise awareness. And it's actually a newspaper, The Guardian, who said, okay, we need to do something. And this was front page news this same year, showing that contamination, especially in Belgium, was a drama, because the measured levels in Belgian citizens, and especially the ones who lived around the 3M factory, were extremely high, much higher than anywhere else in the world. Okay? Epidemiological studies also show the relationship between exposure to PFAS and all kind of major risks for women's health. Okay, let me give you more content on that. Normally, all toxicants are stored in bone tissue, in fat tissue. PFAS undergoes the enterohepatic recirculation, so it means it's released via bile in our intestines, but the majority of the bile is recycled. Okay, now, if it's recycled, the PFAS in serum binds to albumin and then crosses the blood follicle barrier. Okay, how is it eliminated? Via kidneys, via menstruation. So in women, we see once they reach the menopause, the elimination will be lower. And of course, in men also, miss a way of elimination. Now, measured effects: depletion of follicular eggs, earlier age of menopause, a lot of infertility, irregular menstrual cycles, reduced levels of steroids like estrogens and androgens. And this publication, 180 women, PCOS, infertility, and this publication showing in all these women high levels of PFAS. Good. How do we measure? What do we measure? It's the dose that makes the poison. The dose is, yeah, the environmental exposure, but also the circumstances, the individual circumstances. How is our immune system? How is our general health status? How do we detoxify? How do we detoxify? Are we good detoxifiers, bad detoxifiers? And usually when we measure, high values mean that there is a current exposure. And of course, accumulation is possible. What is testable? What is not testable? Nitrogen oxides and toxic dust are not measurable. Goal is to help minimize exposure. So that's number one. We need to limit, reduce the exposure. We need to change things in our life. Open windows for increased exchange. Take off shoes indoors, what I think is a general tradition in some Scandinavian countries. But if you go down more to the south, everyone is still carrying shoes inside. Eliminate all kind of perfumes in cosmetics, because usually they need phthalates and other organic compounds to bind them. Regularly wet dust. Low food chain food, organic food. Eliminate canned food. Minimize plastics, packaging in contact with food. Filter drinking water. And avoid dry cleaning. What else? What are the supportive treatments that we could figure out? Well, detoxification. Let's see how the detoxification works, and maybe we can improve systems. And this is basically our model of detoxification. Stage 1. Exposed to toxins, we transform toxins. And if we say we transform, well, the cytochrome enzymes are in charge, and they will actually, let's say, activate the toxins and prepare the toxins for stage 1, stage 2. In stage 2, conjugation. So we make the toxicants, the activated toxicants, water soluble. And in stage 3, we eliminate via bile, stool, urine. So cytochrome enzymes are in charge for phase 1. In phase 2, the conjugation, different enzymes, a glutathione group could be attached, or methylation, glucuronidation. Different enzymes like glutathione transferase are in charge. Clinical intervention was what's possible. We know that the cytochrome enzymes responsible for stage 1 are very sensitive, are very prone to polymorphisms, to genetic changes. But we also know that they are very sensitive to pollution. So CYP1A is responsible for the detoxification of polycyclic aromatic hydrocarbons like smoking, PCBs. And a lower activity of 1A means that you're more vulnerable for toxicity. But watch out, if you have higher activity, you need to make sure that your phase 2 gives adequate support. Modulation of enzymes. Can we modulate the enzymes in stage 2? Like, for example, glutathione S transferase. That's a system of 6 different enzymes, and they bind glutathione to the toxins. We know that the availability of glutathione is different in person to persons. We know we have systems to increase our glutathione levels, like liposomal glutathione is increasing our bioavailability of glutathione. and methylation, also stage 2. Now, in our models where we try to optimize this process, it's certainly interesting to see what the contribution is of NERV2. And NERV2 is a transcription factor. If we are in danger, if we're exposed to toxicants, or if we experience a lot of oxidative stress, automatically we activate NERV2. And NERV2 is a transcription factor, so moves directly to the nucleus, binds to the promoter region of the genes, what we also covered at the start of my presentation, and then, decides on the expression. So if we can activate NERV2 properly, we will induce more activity of mainly the phase 2 detoxifying enzymes. And this NERV2 system, watch out, because if we're getting older, it declines. And different studies show that animals deficient in NERV2 are much more vulnerable for every kind of toxicity. So molecules that could activate NERV2 and make our phase 2 enzymes in detoxification much more powerful are specific broccoli extracts, like glucoraphanin, the precursor of sulforaphane, but also curcumin, resveratrol, garlic have a positive effect on NERV2. That's glucoraphanin, the precursor of sulforaphane. Sulforaphane is not a stable molecule, so we use specific extracts from broccoli as a precursor. So, in a general way, if we think and if we see and analyze how we could improve this system, well, vitamin B, coactive vitamin B, are the cofactors of the cytochrome enzymes, so they induce the activity of the cytochrome enzymes, that's good. Then broccoli extracts to work on NERV2, more glutathione availability, and molecules like EGCG from green tea and resveratrol, because they specifically induce the efficacy of glutathione S transferase and UDP glucuronil transferase. Next to this, probiotics, because with probiotics you will limit the intestinal uptake. And in a complete summary, lipid replacement therapy, yes, makes sense, because we limit the mitochondrial damage responsible for liver injury and much more. And possibly butyrate, because the colon bacteria responsible for the synthesis of the short-chain fatty acids are extremely affected by environmental pollution. That was my last slide. So Gillian, really fantastic. I stick to the plan. Thank you for your attention. I hope the English and also the German translation was understandable. And I'm all ears and available if you have more questions.
Thank you very much indeed. Brilliant as always. Any questions at all? One thing I noticed, Dr. de Zadelaar, is that you didn't notice a sort of elephant in the room. I'm sure there was a reason for that as well. But do we have any evidence yet on how the lipid nanoparticles of the CVVs have affected the bloodstream and the liver?
Well, I think it's totally right what you say, Gillian. I think here today I limited my lecture to a couple of environmental pollutants, but I'm sure we could fill days and days of lecturing with the effects that other pollutants, like the microparticles that you say, how they affect.
But there's not much evidence in yet of that, and nobody's doing the research because they're not being funded.
No, it's not funded because actually the ones who could fund research will never do it. And it's, I think, of course, I don't want to end up this talk in some kind of political discussion or whatever, but it's often the problem. We saw it with Monsanto about Roundup. We see it now with Belgium, with the 3M, and it's sometimes really getting ridiculous because at some point in Belgium with the 3M, with the measured levels of PFAS, well, a family actually decided to have levels measured, parents and 3 children, and of course it was confirmed extremely high levels. And then they went to court and they said, well, okay, this is what we measured, this affects health, we are very well documented, so yeah, can we talk about this? Are you, as Belgian authorities, will you do something about 3M, or at least is there a financial compensation? And finally, court decided that the 5 members of the family, well, they received €1,000 each, what was actually not enough to cover the costs of the lawyers. And this was actually decided because they said, well, you know, okay, you're right. We measured toxicity, but we have no data showing the long-term toxic effects in children. So there is no basis for doing more than this. So yeah, this is pretty ridiculous, but it's a fact that, you know, you have health concerns, you have economical concerns, political concerns are somewhere shifting between both, and finally we end up in situations where nothing really happens, and we will have more and more induced chronic infections on the long term. The incidence for Hashimoto is doubled, tripled, whatever, and yeah, we actually don't do much about that. So,
well, maybe we'll have more on that next year. Thank you.
okay.
Any other questions at all?
Thank you.
Okay, well, Dr. Polderdaz-Sadler will probably be around for another couple of hours, will you? Until the end of the conference? Lovely, okay. Well, thank you very much indeed. Yeah. We'll be going on now. In a couple of minutes, we finished just a little bit early. We'll be going on to Dr. Med Daniela Hudi. Oh, you are here, fantastic. Thank you. Dr. Hudi will speak in German, if that's okay. Is there anybody here who would have difficulty with that? I mean, we'll have the simultaneous translation, so I hope that's okay. Jim, is that all right for you? Super, you've got the translating microphones. Okay. Well, Dr. Hudi trained as a pharmaceutical technical assistant initially in 1997 to 2000. Then she attended medical school in Cologne and received her MD in 2008. She worked at the Clinic Solingen, had a residency in pediatrics and internal medicine and surgery. And since then, she's had many different appointments, both in Germany and abroad, for example, in Honduras, Central America, Mozambique. And since 2018, she's been working at the St. Georg Clinic in Bad Aiblingen, and she has a key position there. And I'm sure she'll be prepared to answer any more questions about her bio, which is quite long, if you'd like to ask her them.
Yeah.
So,
We'll keep it short.
anything further that's
That's it,
important?
we'll keep it short.
Okay, thank you so much. So she'll be talking about chronobiology of chronic inflammation. Thank you very much. Dr. Hudi, when I hold up and say 15 minutes to go, that's only
Perfect.
15 minutes until the end of your talk, but then there will be
Exactly.
another 10 minutes for questions.
Okay, no problem.
Okay,
We'll get it on. Thank you.
thank you.
So most warm welcome from my side as well, and I hope you will forgive me that I will continue in German then, because since everything what is more or less our everyday work is happening in German, so thanks to the simultaneous translation, I'm sure you will be able to follow quite well. Also noch einmal vielen Dank auch an die Organisatoren für die Einladung. Ich begrüße diejenigen, die hier noch tapfer bis zum Ende durchgehalten haben. Ich nehme an, dass online noch ein paar zugeschaltet sind. Ich habe ein Thema gewählt, das so ziemlich jedem, glaube ich, der hier im Raum ist oder mit irgendeiner medizinischen Tätigkeit verwandt ist, ob als Arzt, ob als Heilpraktiker, als vielleicht anderweitig auch irgendwo im naturwissenschaftlichen Bereich arbeitende Tätigkeit, immer wieder diesen Begriff der Chronobiologie aufwirft. Und per Definition sind wir sicher alle damit vertraut und sagen, ach ja, das hat ja irgendetwas mit Zeit und der Biologie zu tun, was der Begriff an sich auch impliziert. Aber erfahrungsgemäß ist tatsächlich der Inhalt dieses Begriffes, habe ich so das Gefühl, im Alltag kaum integriert. Wenn man sich tatsächlich die Definition an sich anschaut, man sagt, es ist eine Lehre von einer inneren Uhr. Eigentlich müsste man die Definition schon leicht korrigieren und sagen, es sind innere Uhren. Im Laufe des Vortrags werden wir so ein bisschen mehr in Detail darauf eingehen. Und es befasst sich und erforscht zeitliche Gesetzmäßigkeiten im Ablauf von Lebensvorgängen. Also es betrifft natürlich nicht nur den Menschen, sondern sämtliche Lebensformen, je nachdem, wie intensiv man sich damit befasst. Und interessant dann aber auch der Synergismus aus dem Ganzen. Dazu werden wir in ein paar Minuten noch kommen, wenn wir uns mit inneren und äußeren Faktoren befassen, die die Chronobiologie jetzt des Menschen vorwiegend betrifft. Das heißt also, die Chronobiologie interagiert in vielerlei Hinsicht und jetzt nur einige Punkte herausgegriffen. Es ist immer der endokrinologische Ablauf im System. Sie korreliert auch mit der Neuro- und der Psychologie und mit der Immunologie. Ich habe jetzt, wie gesagt, nur so einige Punkte herausgegriffen, die jetzt heute und vor allem in diesem Setting von diesem Wochenende wahrscheinlich am interessantesten sind. Vorab nochmal eine Definition des Rhythmus, die jetzt nicht unbedingt hochwissenschaftlich und biologisch klingt, aber ich habe sie bewusst mit eingebaut, dass man sich einmal kurz den Begriff des Rhythmus noch einmal vergegenwärtigt, was es eigentlich heißt. Wir sprechen oft von Rhythmen, wenn wir Musik hören, und ich glaube, keiner von uns würde gerne irgendwo teures Geld für Opernkarten ausgeben, wenn die im Orchestergraben nicht abgestimmt aufeinander spielen würden. Es würde schlichtweg in den Ohren wehtun. Wir würden unser Geld zurückverlangen und sagen, ich komme nie wieder, das hört sich ja schrecklich an. Wenn aber so ein harmonischer, wie es hier heißt, sich regelmäßig wiederholender, wenn es ein systemhaft gegliederter Ablauf ist, wenn es schön klingt, wenn es gleichmäßig vibriert, wenn es einen bestimmten Rhythmus hinterlässt, der auch einen gewünschten Erfolg, zu einem gewünschten Erfolg führt, dann empfinden wir das als funktionierend und angenehm. Das heißt, dieser Begriff des erhaltenen Rhythmus oder auch möglicher Störfaktoren ist jetzt so einer der Kerngedanken, der uns jetzt hier in dieser Betrachtung begleitet. Und ich habe jetzt hier noch einmal so bezogen auf die Zeit, weil Rhythmus und Zeit sind Begriffe, die eng aneinander gekoppelt sind, habe ich jetzt ein bisschen in ein paar Zitaten hier zum Ausdruck gebracht, die sich teilweise auch ein bisschen, ich würde sagen schon fast ein bisschen ins Philosophische hineinbegeben. Und Spork ist jemand, der 2004 in einem seiner relativ aktuellen Werte, der übrigens jetzt auch sehr viel über die Gesundheitserhaltung spricht. Er sagt, dass die Zeit das Leben umhüllt wie ein Bündel unterschiedlich großer, konzentrischer Kreise und das Leben selbst entwickelt seine eigenen spiegelbildlichen Zyklen, damit es sich in der Natur zurechtfindet. Schlicht und weg, um zu überleben. Oder Dunlap hat es 98 in Form von Kreisen zum Ausdruck gebracht und sagt, und darin lauter Kreise innerhalb von Kreisen. Also circa-annuale Rhythmen, lunare Zyklen, Halbmondzyklen, tägliche 24-Stunden-Zyklen. Das sind alles Rhythmen, ob wir wollen oder nicht, sie sind da. Die Frage ist jetzt nur, wie gut haben wir uns, unsere Gesundheit und womöglich die Krankheit da hinein integriert. Und jetzt kommen wir in diesem Zusammenhang auf ein paar Definitionen, die ganz wichtig sind, um zu verstehen, inwiefern stören oder unterhalten wir diesen Rhythmus von innen oder von außen. Und dann kommen zuerst per Definition die Exorhythmen dazu. Sprich, das sind Schwankungen biologischer Funktionen infolge von rein passiver Steuerung. Sprich, das sind Phasen, die durch geophysikalische Einflüsse, also die, auf die wir definitiv menschlich gesehen nicht wirklich Einfluss haben dürften, und die den inneren Rhythmus bestimmen. Also das ist zum Beispiel durch die Erdrotation erzeugt und somit dann gebunden an die lunaren, also an die Mondphasen und an die Sonne gekoppelte Zyklen. Also als Beispiel, der eine sagt, Vollmond macht mir nichts, und der andere sagt, Mensch, es ist schon wieder Vollmond und ich kann eine Woche vorher und 3 Tage danach nicht mehr schlafen. Wäre ein typisches Beispiel für einen Exorhythmus. Kombinierte Exo- und Endorhythmen sind Rhythmen, die vom Organismus selbst erzeugt werden, müssen aber von periodischen Umweltreizen mit einer ähnlichen Frequenz synchronisiert werden. Das heißt, es wäre hier zum Beispiel diese typischen zirkadianen Rhythmen, circa lunaren, annualen oder Tidalrhythmen. Und sie haben immer einen adaptiven Charakter. Das heißt, das System oder der Körper ist in der Lage, sich anzupassen. Und rein Endorhythmen sind spontan, sind unabhängig von äußeren Zeitgebern, dafür aber innerhalb des Organismus mit anderen spontanen Rhythmen koordiniert und verbunden, wie zum Beispiel Herzfrequenz und Atmung. Vor allem ganz imposant natürlich nachts zu beobachten, wo definitiv keine bewusste Steuerung darauf möglich ist. Infradiane Rhythmen kommen, wenn man höchstens vielleicht von irgendwelchen saisonalen Einflüssen spricht, selten oder werden selten berücksichtigt. Ich weiß nicht, ob jemand von Ihnen vielleicht in seinem beruflichen Alltag, ich habe das ein paar Mal mit Patienten gemacht, die sich bei uns in der Sprechstunde befinden, wenn es um allgemein eben Umstände geht, wo jemand sagt, Mensch, eigentlich habe ich immer wieder so Phasen. Ich habe das Gefühl, ich werde immer kränker, immer älter, aber zum Glück nicht immer in derselben Geschwindigkeit. Also es scheint immer wieder rhythmisch mal nach unten zu gehen, dann stagniert es, dann bleibt es, dann geht es nochmal nach unten. Manchmal gibt es wieder einen kleinen Ausgleich nach oben. Aber es ist interessant, tatsächlich dazu gibt es auch genug Abhandlungen über die sogenannten Septenien, nämlich die Tatsache, dass der menschliche Körper sich im 7er-Jahresrhythmus verändert. Sprich, wenn wir es jetzt kurz durchlaufen, im 7. Jahr ist das Kind ungefähr schulreif. Mit dem 14. Jahr tritt es in die Geschlechtsreife ein. Mit 21 gelten wir als meistens körperlich gesehen junge Frauen etwas schneller als jüngere Männer, die haben noch mal einen Schub, aber mit circa 21 sind wir körperlich ausgewachsen. Mit 28 gelten wir zusätzlich auch mental und intellektuell eigentlich auf dem erstmal lernbar und beeinflussbaren Höhepunkt. 35 kommt schon eine gewisse Portion an Erfahrung hinzu. 42 baut sich die Erfahrung tatsächlich schon zu einer ordentlichen, schwungvollen Spitze auf, aber langsam, aber sicher kommen die ersten körperlichen Veränderungen hinzu, und zwar heutzutage immer früher, gerade unter den Frauen beobachtet, dadurch, dass der Wechsel immer häufiger zu der Zeit schon sich spürbar macht. 49 ungefähr für viele Frauen, dann wenn nicht mit 42, spätestens mit 49 oder dann bei Männern die sogenannten Wechseljahre. Mit 57 werden schon tatsächlich bestimmte körperliche Kräfte mehr nachlassen, aber dafür nimmt das geistige Niveau recht zu. Und mit 63 sagt man, und diesen Punkt fand ich interessant, mit 63 ist das geistige Niveau das erste Mal stärker als das körperliche. Im Grunde genommen eigentlich kann man es auch als etwas Positives betrachten. Das heißt, auch wenn der Körper dann vielleicht nicht mehr so ganz will, kann der Geist einiges ab dem Zeitpunkt übernehmen und dennoch tatsächlich einen vorzeitigen Alterungsprozess noch sehr imposant verlangsamen. Ich habe mich jetzt bei den Septenien etwas länger aufgehalten, aber tatsächlich vielleicht bewusst so ein bisschen als Ansporn. Das hilft sehr zu verstehen, warum manche Menschen tatsächlich so immer wieder nur zu einem bestimmten Zeitpunkt gefühlt ein Tief erleben und sich das dann doch wieder aufsattelt. Und das kann man durch so eine Erklärung manchmal sehr hilfreich den Leuten auch klar machen, dass es jetzt nichts ist, wo der Körper nicht Wege und Möglichkeiten hätte, damit umzugehen, wo er uns nicht damit ausgestattet hätte, diese Phasen auch ohne größere Probleme zu überleben. Die biologische Zirka-Annualrhythmik, also die Jahresrhythmik, ist zum Beispiel jetzt das, was wir so bezogen auf die einzelnen Jahreszeiten kennen. Das ist jetzt relativ geläufig. Die lunare Rhythmik mit dem Klassiker Menstruationsrhythmik, wo bestimmte Symptome oder Zustände des Körpers immer reproduzierbar gemessen werden können, die dann auch zeigen, dass solche Rhythmen, ob wir wollen oder nicht, wiederkommen. Und die circa-septane Periodik, sprich der Wochenrhythmus, das ist jetzt nicht nur eine willkürliche Einteilung der Woche von 7 Tagen, sondern tatsächlich, hier habe ich mal eine etwas ältere Arbeit rausgesucht. Das ist interessant, die ist von 65. Das heißt, dieses Thema ist nicht so neu, wo man beobachtet, dass die 17 Ketosteroidausscheidung im Urin tatsächlich ungefähr sich immer an einem Peak alle 7 Tage befunden hat. Das heißt, der Mensch ist so getaktet, dass er ungefähr in einem 7-Tage-Rhythmus, also auch inkludierend gewisse Ruhepausen an einem oder bis 2 Tagen, tatsächlich von Haus aus, wenn man jetzt auf so etwas schaut, dafür ausgerichtet ist, alle 7 Tage ungefähr auch so eine Periodik aufzuweisen. Jetzt nochmal etwas genauer zu der Chronobiologie und der Forschung, die sich die sich schon 2017 tatsächlich mal wieder dann gemeldet hatte, obwohl, wie wir gesehen haben, es gibt deutlich ältere Arbeiten, die sich mit der Chronobiologie beschäftigen. Aber erst interessant wurde es 2017, als die 3 Herren, die hier genannt sind, Hall, Rosbash und Young, dann den Nobelpreis dafür bekamen, als sie dann die Gene beim Namen genannt haben, die für die innere Uhr kodieren. Ursprünglich hatten Hall und Rosbash schon 1984 das sogenannte Period-Gen definiert, was zunächst die nächtliche Ansammlung von diesem Period-Protein, wofür es kodiert, und im Zellkern so lange gelagert wird, bis es tagsüber zu einem gewissen Abbau kommt. Es hemmt sich letztendlich gegen sich selbst und über den negativen Feedback wird sich diese Synthese nach oben und nach unten bewegen. Das waren die Anfänge und zu der Zeit dachte man noch eine Weile, dass es nur ein einziges Gen gibt, das die innere Uhr reguliert. Bis dann Yang 10 Jahre später nicht dann einen weiteren wichtigen Schritt gegangen ist und das sogenannte Timeless-Gen beschrieben hat, welches dann tatsächlich auch an dasselbe Protein gekoppelt ist, aber im Zellkern über die negative Rückkopplung seine Produktion blockiert. Dadurch hat man dann schon eine etwas genauere Abfolge von diesen Proteinen rauf und runter beschreiben können. Und dann haben sich dann im Laufe der Jahre in den 90ern noch einige an das Clock-Gen gewagt, also das war dann schon das dritte Gen, das identifiziert wurde, was aber tatsächlich dann ganz entscheidend zum Verständnis der Cortisolpendelung beigetragen hat. Es wirkt nämlich im Hypothalamus und da hat man dann zum ersten Mal beschreiben können, dass tatsächlich die 24-Stunden-Rhythmik über das Cortisol ja dann nicht nur lediglich über einen willkürlichen Ausstoß des Cortisols aus der Nebenniere herrührt, sondern tatsächlich, dass es dadurch Proteine gibt, die durch die Kodierung im Hypothalamus den Reiz auslösen. Des Weiteren hat dann wieder derselbe Yang, den wir jetzt zuvor von 94 erwähnt hatten, nochmal das Gen Double Time, das ist jetzt das vierte, entdeckt, welches für das Protein kodiert und für das Period-Gen, also das war das erst entdeckte, welches nachts ansteigt, dann auch nochmal zusammen oder im Grunde genommen abwechselnd gegeneinander steuert. Die Schwingung wird sich von dem Period-Gen dadurch verändern und es wird einen oszillierenden Kurvenverlauf geben. Und dadurch hat es tatsächlich diese zirkadiane Rhythmik gegeben, die von hell-dunkel innerhalb von 24 Stunden sich einmal abwechselt. Das heißt, alle diese Komponenten, wenn sie synchronisiert ablaufen, werden sie den 24-Stunden-Rhythmus festlegen, unabhängig vom Licht. Dazu hat es auch ausreichend sogenannte Bunkerexperimente gegeben, wo die Probanden komplett lichtfrei über mehrere Monate beobachtet wurden, natürlich unter sehr standardisierten und gemessenen Bedingungen, wo sich trotz dessen plus minus eine ca. 24 bis 25 Stunden Rhythmik ergeben hat, ohne Lichteinfluss. Also doch der Beweis, dass es synchrone Uhren gibt, die auf Genebene festgelegt sind, die lichtunabhängig sind. Diese Kurven sind mit Sicherheit Ihnen allen bekannt. Es handelt sich um die Cortisol- und die Melatonin-Tagesrhythmik. Und wie wir sehen, sind sie natürlich komplett entgegengesetzt gerichtet. Das Cortisol ist etwas, was letztendlich idealerweise eine regelmäßige Ausschüttung hat, die morgens bedeuten würde, dass wir mit einem Peak aufwachen, dass wir im Laufe des Nachmittags nach unten gehen und im Laufe der zweiten Nachthälfte, dass es sich wieder aufbaut und entsprechend die Aufwachphase initiiert. Und das Melatonin, welches sich aber auch erst dann ausschütten wird, wenn der Cortisolspiegel auf einem Minimum liegt. Und das ist das, wo wir heutzutage zahlreiche Messungen bei Patienten, weil wir bei uns in der Klinik haben es mit teilweise sehr schwer kranken, chronisch kranken Patienten zu tun, sei es jetzt eine onkologische Problematik, die dahinter liegt, oder auch sehr viele chronische Borreliose-Erkrankte, wo die Tagesrhythmik komplett aufgehoben ist. Und dann geht man hin und möchte so eine Messung durchführen. Sie ist alles andere als so typisch, wie sie jetzt hier auf diesem Schema dargestellt ist. Und ich habe hier jetzt, ich hoffe, das ist so ein bisschen, ja, die Qualität von dem, es wird sich noch halbwegs lesen lassen. Die Qualität von dem Dia zeigt hier etwas, was mit bestimmten Hormonen und Transmittern, Neurotransmittern vor allem auch zu tun hat, die abhängig von der Tageszeit auch entsprechend ihre maximale Konzentration hat, beziehungsweise auch den maximalen, die maximale Wirksamkeit entwickeln können. Und wenn man sich das ein bisschen genauer anschaut, also wie gesagt, das kann man, solche Grafiken kann man sich zu Genüge in den Veröffentlichungen anschauen. Aber ganz interessant ist, wenn man als Beispiel sich das T3 mal anschaut. Also da wären wir jetzt hier bei den Schilddrüsenhormonen. Moment, jetzt müssen wir mal kurz gucken. Hier, genau, hier sind wir bei der Schilddrüse. Hier sind wir bei dem T4 und hier sind wir bei dem T3. Die klassische Endokrinologie und die innere Medizin, wenn wir die Schilddrüse substituieren, geben wir gerne ein T4-Präparat und sagen, ach, der Körper macht das schon, der macht schon sein T3 draus. Wir lassen alles morgens früh brav schlucken, weil der Stoffwechsel soll ja in Gang kommen, bevor wir etwas gegessen haben. Vergessen aber, dass unter Mangelzuständen, zum Beispiel wenn Jod fehlt, es gar nicht zur nötigen Konversion zu T3 kommen wird, das eigentlich, so wie wir es hier entnehmen können, seine Hochzeit in der Nacht hat. Das heißt, eine mangelnde Konversion zu T3 wird allein schon durch das Ausbleiben des Effekts von T3, das wir eigentlich nachts erwarten, wird den Stoffwechsel dermaßen verlangsamen, dass die Prozesse, die für die Nacht gedacht sind, nicht ablaufen werden. Und welche das sind, das kommt jetzt gleich nochmal auf einer Folie, wo wir uns ein bisschen die Hormone anschauen werden, die nachts wichtig sind. Es kommt aber jetzt hier mit dieser Folie, wollte ich jetzt einmal nur, ohne dass wir jetzt jeden einzelnen Pfad der Pfeile nachgehen, aber dass wir mal verstehen, warum tatsächlich diese Vernetzung zwischen dem Psycho-Neuro-Bereich, aber auch dem immunologischen Bereich, warum diese Vernetzung so dicht ist und warum das alles Prozesse sind, die nicht nur einen Weg geradeaus gehen, sondern angefangen tatsächlich über den Nucleus suprachiasmaticus, wo die eigentliche tatsächlich durch den Lichteinfall gesteuerte Tagesrhythmik Signale weitergibt an die Hypophyse, an den Hypothalamus, wo das vegetative Nervensystem, das endokrine System initiiert werden, um tatsächlich übers Immunsystem sich in zwei Richtungen aufzugabeln. Entweder, dass die Bewältigung und die Körperleistungsfähigkeit auf einem guten Level bleibt, oder dass es Richtung Krankheit geht, dass es Richtung Autoimmun, Infektionen, infektiologischen Prozessen geht und über eine Rückkopplung. Und das ist das Problem. Die Rückkopplung, die hier unten aufgeführt ist, dann leider wieder seinen Weg nach oben nimmt, wo tatsächlich dann dieser Prozess entweder nochmal stabilisiert oder komplett zum Kollabieren gebracht wird. Die psychologischen Komponenten, die befinden sich hier dann noch einmal, die tatsächlich entweder wieder relativ direkt mit dem Immunsystem gekoppelt sind oder über Affektsignale wieder ins zentrale Nervensystem zurückgeführt werden. Ich wollte uns noch einmal kurz die Schlafphasen in Erinnerung rufen, damit wir dann gleich die Hormone, die zu der jeweiligen Phase gehören, die den zirkadianen Rhythmus bestimmen, damit wir das nochmal verstehen, weil wir tatsächlich heutzutage es mit einer extremen Schnelllebigkeit zu tun haben. Ich weiß jetzt nicht, wenn ich mal unter den Anwesenden fragen darf, wer von uns ist um Punkt 9:30, 10 abends schon im Bett? Na? Gut, es sind schon ein paar, sehr schön. Das ist die Einschlafphase und die Leichtschlafphase. Teilweise schon ein moderater Übergang schon auch in den leichten Tiefschlaf. Zu dem Zeitpunkt, es sind wirklich erstmal nur einige wenige Minuten, wo man auch selber merkt, dass manchmal die Muskeln so ein bisschen zusammenzucken. Die Entspannung nimmt dann rapide zu, der Puls wird sich verlangsamen, die Atmung wird tiefer werden und physisch und psychisch werden dann langsam die wichtigsten Phasen eingeläutet, nämlich wenn wir uns dann schon im Tiefschlaf befinden und da sind wir schon am Mitternacht vorbei. Und in dieser tiefen Entspannung ist die Atmung sehr rhythmisch, Muskel- und Hirnaktivität tatsächlich auf ein Minimum beschränkt. Welche Prozesse endokrinologisch dahinter stecken, werden wir gleich kurz danach erklären. Vor allem um zu verstehen, warum dann die 5., die Traumschlafphase oder die sogenannte REM-Phase, führt sicher auf den Begriff dieser sogenannten des Rapid Eye Movements, wo die Augenoszillation tatsächlich so circa 10 Minuten lang diese REM-Phase kennzeichnet. Zu der Zeit wird sehr intensiv geträumt, die Muskulatur ist dabei tiefenentspannt. Zum Glück, es ist ein Schutzmechanismus, ansonsten würden geträumte Bewegungen ausgeführt werden. Dennoch passiert es ab und zu mal. Und in dieser letzten Schlafphase werden sich diese REM- und die Non-REM-Zeiten mehrfach abwechseln. Diese Phase ist extrem wichtig, und zwar für fast alle Regenerationsprozesse. Welches Hormon dem voranschreitet, das sehen wir gleich, aber wenn man sich das so anschaut, diese Phasen, die hintereinander ablaufen, stellt sich die Frage, ja, welche ist denn die wichtigste? Und ich glaube, das ist jetzt schon fast eine rhetorische Frage, weil so wie es hier dargestellt ist, sind die ersten Phasen nicht wichtiger als die mittleren oder als die Schlussphase, wo es in den REM-Schlaf reinkommt, weil die Hormone, die das steuern, hintereinander ablaufen und ohne den Vorgänger, der eigentlich aktuelle, nicht wirklich zur Geltung kommen kann. Das heißt, dass wenn wir jetzt ungefähr bei 22 Uhr schauen, was passiert, ist es die absolute Hochphase des Wachstumshormons. Wir wissen, Kinder haben natürlich deutlich höhere Konzentrationen des Wachstumshormons. Deswegen sagt man auch, Kinder wachsen im Schlaf, und zwar tatsächlich in der ersten Nachthälfte. Da sind die Konzentrationen auch bei Kindern deutlich höher als tagsüber oder in der zweiten Nachthälfte. Es ist logisch, das Wort sagt es schon, Kinder wachsen zu der Zeit, aber wir Erwachsene, wenn wir nicht mehr wachsen müssen, wir regenerieren zu der Zeit. Zu der Zeit haben wir deutlich weniger Wachstumshormon im Serum messbar als die Kinder, aber dennoch eine gewisse Konzentration muss da sein. Wenn sie nicht da ist, wenn diese erste Regenerationsphase in der ersten Nachthälfte bis circa Mittag unter Entspannung nicht passiert, wird ab Mitternacht bis circa 2, 3 Uhr das Melatonin nicht effektiv arbeiten können. Das Melatonin wird fälschlicherweise meistens nur als das Schlafhormon bezeichnet. Und das ist etwas, was, wenn man sich mit Patienten unterhält, die sich über Schlafstörungen beklagen, wenn die sagen, ja, ich schlafe so schlecht und ich will die vom Hausarzt verschriebenen Schlafmittel gar nicht nehmen, darf ich es mal mit dem Melatonin probieren? Und dann laufen die in die Apotheke und kaufen sich ein Präparat von 1 bis 2 Milligramm oder das Spray und trauen sich nicht mehr als 1, 2 Hübe zu nehmen und sind dann gerade mal bei so im Durchschnitt 1 Milligramm pro Hub. Und dann sagen die, ja, es hat nicht viel gebracht, da konnte ich auch nicht schlafen. Und dann muss ich die so ein kleines bisschen enttäuschen, wenn ich sage, ja, von 1 Milligramm wird wahrscheinlich bis auf ein paar Ausnahmen auch noch nicht viel passieren. Es gibt tatsächlich ausreichend Studien, die zeigen, dass das mit dem Melatonin, was man ja sonst selten sagen darf, eigentlich nicht viel passieren kann. Es kann nicht wirklich was nach hinten losgehen. Und die sicheren Dosen rangieren alle zwischen 10, 15, 20 und nicht nur das. Laut Professor Edinger, der sich sehr damit befasst hat und auch Studien bei Brustkrebspatientinnen betrieben hat, wo er gezeigt hat, dass bis zu 600 Milligramm pro Tag transdermal aufgenommen ganz andere Effekte aufweisen, nämlich gerade bezogen auf den Alpha-Estradiol-Rezeptor, wo es gar nicht mehr um diese Schlafinduktion geht, sondern das Hormon tatsächlich als Modulator auftritt. Und als Modulator aufzutreten oder direkt nur einen Pfad einzuläuten, das wissen wir aus der gesunden Physiologie, dass das komplett unterschiedliche Effekte sind. An der Stelle gerade, wo es sich jetzt nochmal ums Hirn handelt, weil wir sagen, das Hirn wird sich ja nachts erholen, wird es nicht funktionieren, wenn das Melatonin die Hirnhemisphären nicht untereinander synchronisiert. Das ist der Grund, warum wir sagen, das, was wir tagsüber gelernt haben, wird sich nachts verfestigen. Das ist die Aufgabe der synchronisierten Hirnhälften und dieser Prozess kann nur passieren, wenn Melatonin vorhanden ist. Interessanterweise wird währenddessen auch Adenosin die Ausschüttung exzitatorischer Neurotransmitter bewirken und das Müdigkeitsgefühl verweilt. Das heißt, das erklärt die Schlafinduktion über den Adenosinschenkel, nicht weil das Melatonin einfach nur irgendein Mittelchen ist, das kurzfristig irgendwo einen Rezeptor blocken wird und dann schlafe ich für ein paar Stunden. Also an der Stelle kann ich Sie nur dafür sensibilisieren, sich mit dem Melatonin ein bisschen mehr zu befassen. Es ist ein unglaublich breites Spektrum. Es hat extrem viel, wie gesagt, als Modulator vor allem mit dem Östrogenhaushalt zu tun. Es hat sehr viel mit dem Leberstoffwechsel zu tun, mit dem Knochenmetabolismus, mit der Haut, das letztendlich alle Symptome sind, wenn eine peri- oder postmenopausale Patientin vor Ihnen sitzt und sagt, ja, ich schlafe schlecht, darf ich Melatonin nehmen? Und dann frage ich konkret diese eben genannten Symptome ab und dann sagt sie, ja, das habe ich ja sowieso. Das heißt, erst einmal hier sich kurz einprägen, Melatonin ist nicht nur ein Schlafhormon. Wenn die Melatoninphase so bis circa 2:30, 3 abgelaufen ist, wird sich der Spiegel nach unten bewegen und ab dem Zeitpunkt wird die Nebenniere, die bis dato, wenn wir an die Grafik von zuvor denken, genug Cortisol ausgebildet haben, um idealerweise das dann ab 4 Uhr ungefähr ins System zu schütten, um den Sympathikotonus zu steigern und die Aufwachphase einzuläuten. Das heißt, wie wir es eben erwähnt haben, wir können und sollten nicht versuchen, die Schlafphasen durcheinander zu bringen. Ich kann nicht erwarten, dass um 10 Uhr abends erstmal die REM-Phase kommt und später entspanne ich meine Muskeln. Genauso kann ich auch nicht erwarten, dass ich mit einem Cortisolspiegel abends zwischen 9 und 10 noch so hoch ist, weil ich dann das Bedürfnis hatte, nochmal so exzessiv Sport zu betreiben, weil Sport ist ja gesund. Aber dadurch werde ich schlimmstenfalls dafür Sorge tragen, dass der Cortisolspiegel so hoch ist, dass das Wachstumshormon keine Chance haben wird, auszutreten. Wenn das Wachstumshormon nicht rauskommt, kommt auch das Melatonin nicht. Und wenn das Melatonin nicht da war, wird nachts alles das nicht passieren, was sollte. Und die Cortisol-Tageskurve, wenn sie abends so übergeschossen ist, wird morgens wahrscheinlich nicht die wichtige Aufwachphase einläuten können, auf die wir so dringend angewiesen sind. Und das sind dann diejenigen, die sagen, ja, ich bin ja eine Eule, ich bin ja keine Lerche. Aber das ist das Interessante, dass, wenn man sich die Leute anschaut, die Lerchen deutlich gesünder durchs Leben kommen als die Eulen. Und wenn man jetzt nachher so ein bisschen den Brückenschlag zur Inflammation machen, dann werden wir es auch leicht verstehen, warum. Also das ist jetzt nochmal so eine Phase, einmal ein Schaubild, das man sich hier anschauen kann. Also hier hätten wir diese gelbe Kurve hier ist die normale, das heißt die Cortisolmenge ist früh morgens hoch, Ausstoß am frühen Morgen im Laufe des Tages geht es runter. Viele erfahren mittags, nachmittags noch einen leichten Schub nach oben, aber gehen dann physiologischerweise wieder runter. Wenn wir vermehrt dem Stress ausgesetzt sind, egal ob das jetzt selbst induzierter Stress ist, ob wir im Stau stehen, ob wir chronisch krank sind und Schmerzen haben. Schmerzen bedeuten Stress. Das heißt, ein chronisch kranker Patient, der Schmerzen hat, wird sich häufig erstmal lange hier in diesem Bereich befinden, wo er eigentlich mit seinem Cortisol fast Tag und Nacht lang überschießt. Aber irgendwann mal hat es sich ausgeschossen. Und dann geht er hier in diese rote Kurve über, in ein sogenanntes Burnout. nennen wir es Syndrom oder Zustand oder wie auch immer. Und dieses Burnout-Syndrom, das wäre jetzt nochmal nicht nur eine tages- oder wochenendfüllende Geschichte, sondern etwas, was, wie wir jetzt sehen, auch mit einer etwas gestörten Tag- und Nachtrhythmik zu tun hat oder der Tatsache, dass wir es vergessen haben, vorgegebene Endo- und Exorhythmen nicht nur abzustimmen, sondern sie überhaupt so, wie sie existieren, zu respektieren. Nochmal die klassischen Effekte des Cortisols, das ist jetzt nur einmal, das ist bekannt. Die Metabolismusaktivierung, die Energiebereitstellung durch Lipolyse oder Glykogenabbau, dass es die Temperatur steigert, dass es die emotionale und kognitive Aktivierung und die Schmerzhemmung kontrolliert und die Entzündungshemmung, aber jetzt mit einem Aber bis zu einem gewissen Grad. Weil, jetzt kommt immer dieses Aber und das Weil bei dem Cortisol, was ja oder andere Cortisone, die wir jetzt durchaus als Synonym, wenn wir sie synthetisch zufügen, wenn wir das jetzt alles in einem Begriff stehen lassen, wissen wir, dass Cortisol langfristig die Wachstumshormonachse blockiert. Und jetzt denken wir aber an das Hormon, was wir so dringend zwischen circa 10 und 12 Uhr nachts brauchen. Und es blockiert die zelluläre Immunantwort und somit eben die unspezifische Entzündungsreaktion. Und das ist das Problem, das heutzutage immer größer wird. Der Mechanismus, der dahinter steckt, dass der zelluläre Weg, der vorwiegend durch zytotoxisch-inflammatorische TH1-Signale gesteuert wird, wird umgekehrt. Und es übernimmt der humorale Weg, der TH2 gesteuert in einen kompletten Toleranzmodus überführt. Das heißt, dann ist es schon das Stadium einer chronischen Entzündung. Ein Herr Bieger, ich weiß nicht, einige hier im Saal bin ich mir sicher, wissen, wer das ist. Es ist ein Laborarzt, der hier in München nicht nur sehr schön bestimmte Werte misst, sondern tatsächlich auch immer wieder Literatur und gute Zusammenfassungen zur Verfügung stellt. Und ich habe mir erlaubt, ein bisschen was aus seiner Abhandlung hier abzulichten, wo nach den Zytokinen, jetzt einmal aufgereiht, wir zum einen die Orte haben zum jeweiligen Zytokin, wo es im zentralen Nervensystem produziert wird. Also wie wir sehen, sind es immer die Astrozyten, immer die Mikroglia oder auch die entsprechenden Endothel- und andere Zellen, die sich in der Umgebung der Neurone befinden. Die Wirkungen, was es jeweils bedeutet, sowohl zentral, aber als auch die neuroendokrinen Effekte. Und worum es mir vorwiegend ging, ist zu verstehen, dass egal über welches Zytokin wir sprechen, es immer hier, wenn wir die neuroendokrinen Effekte anschauen, fast durch jedes Zytokin induziert, können wir in die Falle der Schlafstörungen reinkommen. Um das kurz zusammenzufassen, über unterschiedliche Zytokine werden unterschiedliche Wege einer Aufhebung der gesunden Tagesrhythmik initiiert. Sprich, ob jetzt dass die Schlafinduktion gestört ist oder dass die Schlaftiefe oder dass die Schmerzen verstärkt werden und dadurch der Schlaf unmöglich wird. Fakt ist, dass jedes Zytokin dazu beitragen kann, die gesunde Rhythmik aufzuheben. Wenn dann irgendwann mal dieser TH2 gesteuerte chronische Entzündungsweg einmal eingeläutet ist und vor allem über das TNF-Alpha und Interleukin 1 sämtliche Systeme, angefangen vom Immunsystem über Haut, Gefäßendothel, Hormone, Nervensystem, Muskelgewebe, Fettgewebe, überall kommt es zu einer Ausprägung, die eigentlich, wenn wir es jetzt alles nochmal zusammenfassen, zum Burnout oder zur chronischen Erschöpfung geführt haben. Und an dieser Stelle jetzt habe ich Ihnen ein paar Arbeiten rausgesucht, Da werden wir jetzt nicht im Einzelnen durchgehen, sondern das, was jetzt gelb hervorgehoben ist oder das, was man jetzt am Titel oder dem Titel entnehmen kann, sind Arbeiten, die alle unterschiedlich alt sind. Das ist hier zum Beispiel eine von 2013, wo der eindeutige Zusammenhang von Schlafentzug und Inflammation hergestellt wird. Das heißt, diejenigen, die weniger geschlafen haben oder sehr unregelmäßig geschlafen haben, haben höhere Konzentrationen an Entzündungsmediatoren im Blut gehabt. Eine andere Arbeit, jetzt relativ aktuell, da geht es um die Telomerlänge und das wird jetzt nochmal so ein kleiner Punkt sein. Gegen Ende möchte ich betonen, dass so dieses Problem heutzutage nicht nur der ständigen chronischen Müdigkeit, auch immer wieder wird man immer häufiger damit konfrontiert, zumindest als Arzt. Ja, was kann ich dafür tun? Ich möchte ja nicht so schnell unter all dem leiden und älter werden. Das ist ein Wunderpunkt, es ist auch gut so. Wir müssen ja nicht alles so kommentarlos über uns ergehen lassen, aber wir verstehen nicht, inwiefern so grundlegende Dinge wie das Nicht-Respektieren des Tag-Nacht-Rhythmuses oder das Nicht-Respektieren bestimmter Abfolgen von Hormonen und von Mediatoren, die sich abwechseln, wie sehr die dazu beitragen können, das eigentliche auf genetischer Ebene, die eigentlichen Steuerelemente eben wie die Telomere, die ja ein gut messbarer Parameter sind, dafür Sorge tragen, dass wir schneller und ungesünder altern. Das heißt, wir wollen nicht alt werden, wir wollen nicht krank alt werden, aber wir wollen auch nicht so viel dafür tun, dass wir es wirklich effektiv verhindern. Das ist eine riesige Schere, die auseinandergeht heutzutage, weil unser Lebensstil wird uns, je schnelllebiger wir sind, eigentlich immer weiter von diesem Ziel entfernen, dass wir auf die Telomerlänge achten. Und da war es jetzt interessant, diese Arbeit bestätigt, dass eben diese sogenannte chronische Schlaf oder die chronische Störung des Schlafes in dieser Gruppe die Telomerlängen, die gemessen wurden, dass sie deutlich kürzer ausgefallen sind, sprich, dass diese Probanden schneller altern. Jetzt nochmal eine Arbeit von 2011, die die REM-Phasen nochmal im Fokus hat, sprich der Entzug der REM-Phasen. Also das ist jetzt dieses ab 4 Uhr ungefähr. Das heißt, jemand, der immer Punkt 4 Uhr, aus welchen Gründen auch immer, vielleicht nicht unbedingt natürlich, wach wird und diese Phasen oder auch etwas eher in der Nacht nicht durchmacht, wird den Entgiftungsprozess in der Leber beeinträchtigen, und zwar negativ beeinträchtigen. Das heißt, die Konzentration der Transaminasen waren in dem Falle deutlich höher gemessen, genauso wie die proinflammatorischen Zytokine, was das Interleukin 1, Beta, Interleukin 6 oder 12 betrifft. Das heißt, je weniger REM-Phasen, umso schlechter die Leberentgiftungsleistung. Und das ist auch nochmal interessant, sich noch einmal im Hinterkopf zu halten, dass die meisten Patienten, die eine Leberentgiftungsstörung haben, und deswegen war es jetzt ganz interessant, auch bei meinem Vorredner, die Beispiele, die er gerade gebracht hat über die Umweltgifte oder auch den Einfluss der, muss man schon fast sagen, der verkehrten Hormone, der Xenobiotika oder anderer endogener Disruptoren. Die eigentliche Hochzeit der Leber ist nachts zwischen 1 und 3. Und wann werden diejenigen meistens nachts wach, die zum Beispiel mit dem Eintritt in den Wechsel auf einmal Schlafstörungen entwickeln? Viele berichten, davon kann ich wirklich sagen, schon Hunderte von Patientinnen, mit denen ich darüber gesprochen habe, die sagen, ich schlafe gut ein, aber dann bin ich wie angeknipst, nach 3 Stunden wieder wach und zwischen 1 und 3 kriege ich die Augen nicht mehr zu. Und wenn man sich dann die Lebersituation anschaut, dann hat man schwarz auf weiß, dass sie verstehen können, warum das so ist. Also irgendwo doch nach dem Motto, schlaf dich schön und schlaf dich schlank. Ja? Noch eine weitere Arbeit von 23, also sehr jung. Da geht es um das, also eigentlich bekannter eher, das Insulin-like Growth Factor wäre eigentlich das Somatomedin C, unter dem Begriff kennen wir es vielleicht eher. Und das ist etwas, was bei Patienten wieder mit einer chronischen Schlafstörung tatsächlich haben sie niedrigere Spiegel. Und da wieder, dummerweise, ist die Leber der Hauptproduktionsort für das Somatomedin C. Und wenn die Leber nicht mehr kann, nicht mehr will und nicht ausreichend entgiften kann, wird sie auch weniger Somatomedin C produzieren. Und das wiederum gehäuft vorkommend bei Patienten mit einer chronischen Schlafstörung. Auch in den letzten paar Jahren leider zu Genüge beobachtet, aktuelle Situationen nach Covid-19, Long-Covid-Patienten, die eindeutig vermehrt alle darüber berichten, dass seitdem die Schlafphasen extrem oder das Schlafverhalten im Allgemeinen extrem gestört ist. Der zirkadiane Rhythmus teilweise komplett aufgehoben ist. Und jetzt fragt man sich, was ist zuerst in den Teufelskreis eingetreten? War es die chronische Entzündung, die das ausgelöst hat, oder teilweise schon sehr schlechte Gewohnheiten? Jemand, der vielleicht diese zirkadiane Rhythmik, dem das eigentlich ziemlich egal war, und jetzt muss er mit so einer akuten, heftigen Infektion zurechtkommen, ist so ein bisschen die Frage, was war zuerst da, die Henne oder das Ei? Noch einmal noch kurz der Begriff eines Inflammasoms. Jetzt nochmal das Gesamtsetting von diesem Wochenende, wo wir uns ständig in dem Kreis drehen, was alles mit Entzündungen, vor allem mit chronischen Entzündungen zu tun hat. Die chronischen Entzündungsreaktionen werden durch sogenannte Inflammasome gesteuert, die sich im Zytosol befinden und über den Caspase-1-Weg zu einer proteolytischen Spaltung führen und dadurch proinflammatorische Zytokine wie das Interleukin 1-Beta und das Interleukin 18 produziert werden und die heranreifen. Sie sind mit Makrophagen assoziiert oder werden auch im epithelialen Gewebe vorgefunden. Und wenn diese fehlreguliert sind, werden sie dafür Sorge tragen, dass es vermehrt zu neurodegenerativen und kanzerogenen Prozessen führt. Autoimmunprozesse werden angefeuert und tatsächlich sämtliche metabolisch vorhandenen Dysbalancen werden dadurch noch leider verstärkt. Das ist jetzt ein bisschen eine Übersicht, vor allem ganz interessant, wenn man von hier oben schaut, also wenn wir uns die pathogenassoziierten Moleküle anschauen oder auch die Schaden, also damage-assoziierten Moleküle anschauen, die dann diese zahlreichen Wege initiieren, führt es letztendlich entweder über den NF-kappa-B-Weg oder über die Caspase-Wege immer zu einer entzündlichen Reaktion, die chronisch werden wird, oder eben, was wir gesagt haben, leider meistens bei kanzerogenen Patienten beobachtet, zu einem Zelltod, wo die Apoptoseprozesse komplett ausgeschaltet sind. Der eigentliche Brückenschlag zwischen den Inflammasomen, die tatsächlich leider bisher, es ist lange her, dass sie das erste Mal beschrieben wurden, aber im Alltag haben sie, befürchte ich, mit all ihren Auswirkungen recht wenig Beachtung bekommen, dass man versteht letztendlich, welchen dichten Zusammenhang es gibt, gerade zwischen den REM-Phasen, und jetzt sind wir wieder in dieser Schlafphase, wo wir zwischen 3, 4 bis 5 Uhr morgens, wo die REM-Phasen dicht einander und die Nicht-REM-Phasen sich abwechseln, dass in dieser Zeit vorwiegend die Kontrolle der Inflammasome vorgenommen wird, beziehungsweise Patienten, die in dieser Zeit unter einem Schlafentzug oder einem Schlafmangel leiden, werden leider die Aktivität der Inflammasome hochregulieren. Das heißt, auch da wieder der direkte Zusammenhang und eine relativ einfache Erklärung, warum Schlafentzug die chronische Entzündungsreaktion befeuert. Es gibt noch ein paar andere, jetzt kurze nochmal nur, wenn jemanden der Titel interessiert, Abhandlungen darüber auch, wie sehr das Nervengewebe an sich dadurch geschadet wird, wie durch die Entzündung nicht nur das periphere Nervensystem geschädigt wird, sondern tatsächlich auch leider, die Vermutung liegt sehr nahe, dass dann die Blut-Hirn-Schranke offen ist, auch dann tatsächlich das zentrale Nervensystem betroffen ist. Nochmal eben schon erwähnt, zelluläres Altern und generell das somatische Altern wird beschleunigt durch chronische Inflammation beziehungsweise meistens durch Telomerlänge bestimmbar und tatsächlich die Befürchtung leider, dass die Umweltkomponenten immer mehr dazu beitragen werden, dass wir, wenn wir sie denn eben gerne angeschlossen an das, was der Vorredner gesagt hat, wenn wir nicht verstehen oder nicht wissen, was wir überhaupt zu entgiften haben oder auf welche Art und Weise oder wo kommt mehr vor, wir aber dabei vergessen, dass dann die Leber eben nicht nur diese eine Noxe zu bekämpfen hat, sondern zeitgleich zahlreiche viele andere, wird es leider ein bisschen schwierig, ein bisschen unübersichtlich. Also, wir haben es geschafft. Die Take-Home-Message wäre, dass das Kennen und Verstehen von den endogenen Rhythmen, die schon vor Jahrzehnten gut definiert wurden, wir haben sie so ein bisschen vergessen. Sie sind aus dem Blickfeld geraten, weil wir beschäftigen uns mit viel dem, was um uns herum passiert, vergessen aber, dass sowohl die Patho- als auch die Salutogenese davon abhängen. Das heißt, die Endorhythmen sind da, ob wir wollen oder nicht. Und sie sind sehr leicht gestört. Sie sind maßgeblich an Induktion inflammatorischer Prozesse beteiligt und die Adaptation und Resilienz nach länger andauernden Stressreaktionen hängt davon ab. Und langfristige Abweichungen der zirkadianen Rhythmik und die chronische Inflammation werden die Alterungsprozesse schneller induzieren. Das ist ein Satz, der vielen Patienten dann sehr wehtut, aber dann manchmal auch so ein bisschen Aufwachen bedeutet, weil sie sagen, naja, ich möchte ja nicht nur gesund werden, sondern ich möchte auch langfristig, wenn es geht, nicht zu schnell älter werden. Also an dieser Stelle bleiben Sie gesund und schlafen Sie gut vor allem. Und bleiben Sie gesund, danke.
Thank you very much indeed, Dr. Hudi.
Welcome.
Fascinating messages there. One question from Jim here. Okay.
That's fine.
It's all right.
You mentioned about hypothyroidism
Yes.
and the taking of your Tyrox T4. Now, I missed exactly when you said you should take it in the morning, in the evening, before going to sleep.
Yeah, that's a good question indeed, because the conventional medicine is mainly, in case of a hypothyroidism, going towards the T4 medication. So it means, in ideal way, the body will make the T3 out of it. But in more and more cases, we see that we can have even a more or less tolerable TSH. T4 is fine, and then you measure the T3, or even if you're more curious, you measure the reverse T3, then you see that it's terribly low. So lab work is perfect, but the patient is tired. Means adding T3, and it's mainly, at least here in Germany, we have one fixed medication where you have T4 and T3 in a relation 4:1. So it means the T3 is automatically added. And in some cases, we see that the definitely well-being is reached when the patient adds a part of the doses in the late afternoon or even at night.
So what you're saying is you should take it at night before.
In case, I wouldn't do it with everybody. I would, you have to observe the patient then over longer time. Mainly, they give you a good hint if they tell you around afternoon or in the evening, I'm very, very, very tired. And if you check the cortisol level, it might be okay, so it means it could be the thyroid. So if the cortisol level in the evening is still fine, then I would try to add the T3 in the evening. Because then the metabolism, which has to be active, a part of it overnight, it's quite balanced, and then they easier shoot up with the cortisol than in the morning. welcome.
Any other questions?
Danke für die Präsentation. Ich bleibe
Gerne.
mal in Deutsch. Ich hoffe, das ist okay. Auf einer Folie war das NSE, die neuronenspezifische Inhalase, erwähnt. Ich messe die sehr, sehr häufig und bei vielen Patienten, gerade mit der chronischen Borreliose oder mit irgendwelchen Disorders, erhöht. Unter der Therapie geht die manchmal nach oben, da bin ich so ein bisschen schockiert, aber ich weiß, dass ich unter meiner Therapie die auch wieder runterkriege. Das große Problem, was wir da haben bei der neuronenspezifischen Inhalase, ist der Referenzbereich. Und da habe ich neulich mit dem Laborarzt gesprochen und der sagt, ja, der Hersteller gibt das an. Ja? Der Referenzbereich geht irgendwie bis 12,5 oder 18 oder sowas, je nachdem welches Labor. Ja, der wird auch als Tumormarker eingesetzt bei Bronchialkarzinom.
Ja, richtig.
Ja? Gut, da sehe ich auch
Oder
Patienten.
Neuroendokrinen.
Ja, da sehe ich auch Patienten mit, was weiß ich, 20, 30, 40, 50. Ja? Nur ich versuche die Patienten auch da, weil für mich ist es ein Indikator für eine Neuroinflammation.
Richtig.
Und wenn ich richtig therapiere und der Patient mitzieht, gehen die Werte runter, deutlich unter 10. Ich versuche so in Richtung 6 zu kommen, was mir nicht immer gelingt. Ja? Aber das ist ein Parameter, der relativ einfach zu akquirieren ist, nämlich aus einem Serum. Ich brauche keine Liquoruntersuchung. Der Wert kommt nämlich in gleichen Mengen im Liquor wie im Serum vor.
Und das ist interessant, nochmal tatsächlich dieser Ansatz, und das würde aber nicht nur fürs NSE gelten, sondern tatsächlich beim CEA haben wir es beobachtet oder beim CA 125er. Tatsächlich habe ich jetzt im Kopf auch jemanden, einen männlichen Patienten, eigentlich mit einem Pankreaskarzinom, wo der CA 125 monströs hoch war. Und das war dann mit Sicherheit nicht der Eierstock, ja, womit es meistens assoziiert wird, aber auch tatsächlich bei dem ein extrem ausgeprägtes Bild einer chronischen Inflammation, die ihn letztendlich das Leben gekostet hatte. Aber das ist, und da gibt es aber auch interessante Arbeiten, wo das Melatonin wieder ansetzt. Deswegen also nochmal auch auf die Gefahr hin, dass ich mich mit dem Melatonin ständig wiederhole, aber es ist nicht nur ein Schlafhormon.
Ich bin der gleichen Meinung, die Dosen, die so kursieren, die sind viel zu niedrig. Also
ja,
ich setze
viel zu
extrem
niedrig.
höhere ein
Ja.
und den Patienten geht es gut. Ja.
Und tatsächlich, also es gibt da nochmal, also falls der Name jetzt gerade nicht nochmal, so Professor Edinger hat da wirklich ganz tolle, oder Pier Paoli ist jemand, der noch ein bisschen länger damit ist, ein Italiener, der sich damit beschäftigt hat und sehr viel gute Literatur auch hinterlassen hat. Also der beschreibt da sehr viel und gerade wenn man sich eben bei chronischen Borreliosen oder wir, die sehr viel auch mit onkologischen Patienten zu tun haben, ist es eigentlich ein Mittel, das schon fast an der Tür vergeben werden müsste, weil es hätte mit Sicherheit mehr als nur eine Indikation. Ja.
Could I ask one question? Can I ask it in English and then you're very
Sure,
welcome to
I'll do my
respond in
best.
German.
Go ahead.
Because I can speak German as well. I have several patients who have fluoroquinolone damage, and you've taken ciprofloxacin, and what I've noticed is that their circadian rhythm completely switches. They're up all day and up all night and have to sleep during the day if they can at all. I think that's the topoisomerase 2 that prevents the DNA of the mitochondria from being able to replicate. And we've done mitochondrial studies on them and found that some of them just have 2 mitochondria per cell. Disastrous. Have you noticed that in patients, and is there anything that you know that can correct at least the rhythm so that they can start sleeping and start repairing? I know it's a big question, but maybe you have a couple of tips.
Yeah, well, indeed, besides melatonin, without repeating myself now all the time, there is something else. It's more from the progesterone corner.
Even for men?
Exactly, even for men. There is a nice, which says why men need progesterone. It's easy to Google it. But it depends how you apply it. Since in our clinic we like to deal exceptionally only with bioidentical hormones. So it means when I speak about progesterone, so it's just progesterone from the directly identical structure to the progesterone that we produce, and men as well. So men produce it in the adrenal cortex, which means applying it transdermally it won't be having an effect which makes you sleepy, because it will support the adrenals, definitely. But if you add progesterone orally, it goes a specific hepatic way, and it produces the so-called allopregnanolone. And that has the effect of relaxing the muscles. And that puts you quite in a nice deep sleep. And the perfect thing is, the duration, the effect lasts like 6 to 8 hours. So it means if you tell the patient, take your, in average, 200 milligrams of progesterone orally at bedtime. You swallow it, try to switch off the light, no screens, no iPhones, no any other gadgets, whatever, and try to relax. So mainly people, I would say the majority indeed of them, feel simply that they fall lightly in a kind of easy state, easily fall asleep, and the effect lasts roughly 6 to 8 hours. I would say perfect to go through the whole night without a hangover next morning and without being addicted to it. So in case like this, where you see that somebody totally turned the rhythm around, I would try to first jump in with melatonin in order to help to cope the cortisol peak, and then add progesterone orally. And doesn't even for men, because for men it has several other definitely beneficial effects, especially protecting the prostate from an estrogen dominancy. Because it regulates against the DHT, the dihydrotestosterone.
Oh, that's fantastic. Thank you very much indeed.
Welcome.
Any other questions?
Könnten Sie noch etwas zu der Dosierung von Hochdosis Melatonin und im Vergleich zur transdermalen Dosis sagen?
Ja, also es ist so, man muss bei der oralen Einnahme bedenken, dass es immer den First-Pass-Effekt gibt. Und der ist nicht gering. Das heißt, wenn jetzt jemand meinetwegen diese fast frei verkäufliche Pille von 2 Milligramm nimmt und sie geschluckt hat, was da ankommt, ist sehr wenig. Einige wenige reagieren darauf. Wenn ich aber jetzt jemanden habe, der das Transdermal anwendet, ist zum einen der First-Pass-Effekt umgangen, das heißt, ich habe keinen Verlust, sondern das, was ich auftrage, meinetwegen, wenn ich jetzt eine 1%ige Transdermal, ein 1%iges Gel auftrage, das sind dann gleich zum Beispiel 10 Milligramm. Das wird sich über Nacht verteilen und da muss man schauen, womit der Patient im Durchschnitt anfangen kann, je nachdem. Vielleicht hat er schon experimentiert mit Tabletten, mit den Sprays oder auch selber schon eine transdermale Zubereitung gehabt, traut sich aber nicht höher zu gehen. Es gibt aber Arbeiten, die tatsächlich zeigen, dass gerade in der Rekonvaleszenz, gerade auch bei Covid-Fällen wurde das ganz imposant beschrieben, in der Rekonvaleszenz von schwersten komplexen Erkrankungen hat man bei Kindern sogar schon Dosen 30 bis 40 Milligramm in den ersten 6 Wochen angewendet. Dann ist man langsam zurückgegangen. Bei Erwachsenen ist man tatsächlich bei 50 bis 80, je nach Körpergewicht, soviel ich weiß. Also wie gesagt, das ist auch bezogen auf diesen eben genannten Herrn Pierre Pauli zurückzuführen. Also wenn man da noch ein bisschen weiter sucht, da wird man es finden. Und nochmal eben die Zahl, die ich von 600 Milligramm genannt habe, das war das, was man bei Brustkrebspatientinnen beobachtet hat, wo es um den Alpha-Östrogenrezeptor geht, wo es um eine gewünschte Wechselwirkung geht. Und tatsächlich diese scharfkantige Eigenschaft des Beta-Estradiols auf dem Alpha-Rezeptor kopiert wird. Und bei diesen Patientinnen über 5 Jahre beobachtet, hat man eine deutlich bessere Lebensqualität und eine deutlich niedrigere Rezidivrate beobachtet.
Thank you very much. Thank you so much, Doctor. That was absolutely fantastic, wasn't it? Brilliant information.
Welcome, welcome. Ja, die kannst mich fragen.
Ja, meine lieben Freunde, Konferenz of Friends, okay? Das ist das Motto, was ihr nach Hause tragt, in euren Herzen tragt, in eurem Geist tragt, in eurer Fachkompetenz jetzt tragt. Ich möchte mich bedanken. Ich möchte mich bei euch bedanken. Ohne euch wäre das keine Veranstaltung geworden. Ich möchte mich bei allen Rednerinnen, Rednerinnen, muss man ja sagen, und Rednern ganz herzlich bedanken. Ich möchte mich bedanken, ohne zu vergessen, die Übersetzerinnen. Toller Job, sollten wir auch mal klatschen. Ich glaube, Sie haben auch mal ein Lob verdient. Unser Tontechniker, sollen wir auch noch mal kurz klatschen, da war gut der Mann. Ja, dann haben wir natürlich noch mehr, wo wir uns bedanken müssen, bei allen Ausstellern, die dürfen wir nicht vergessen. Ohne Aussteller wäre das nicht möglich geworden, auch die etwas gesponsert haben zu dieser Veranstaltung unter Freunden. Und ich muss überlegen, wen können wir noch, den Hausmeister müssen wir einbeziehen, die Laborhelferinnen natürlich, die auch das Catering, Hans-Peter, das Catering, Applaus, ich denke, das war einfach toll. Das Essen war einzigartig, so die Vielfalt hatten wir auch selten.
Could I just add one thing there, which is that if you would like to write sort of a thank you to the catering team, then Marcus has the email address to write to.
Well, I know there's a poster on the left side, and down there's the email address, so you can leave a review on Google. So he's happy about that. So
he especially requested it. I think it's contact written with a K at gil-food.de. Nice and easy.
Ja, jetzt müssen wir weiter überlegen, bei wem müssen wir uns denn noch bedanken? So, Hans-Peter, du hast bestimmt noch eine Idee. Den Hausmeister haben wir schon genannt. Nein, nein. Nee, da fehlen noch viel wichtigere Leute, viel wichtige Leute. Wir müssen uns, ich glaube, Ladies first, würde ich sagen, zunächst mal bei meiner Frau bedanken, die uns das überhaupt hier ermöglicht hat, in Gilching im Hintergrund zu arbeiten, nicht im Vordergrund zu sein, im Hintergrund uns das überhaupt zu ermöglichen, über den Bürgermeister der Stadt, dass wir in diese tolle Halle gehen durften. Wir müssen uns an den Räumen und natürlich von der Organisation meiner Frau dieser Räume bedanken. Vielen Dank nochmal. Ja, auch es geht weiter. Jetzt kommen wir an die Moderatorinnen. Ja, Gillian, ein brillanter Job, den du gemacht hast, finde ich, in der Moderation. Und nicht zu vergessen, Frau Professor Gilbert, die uns leider ausgefallen ist. Ich habe das war, glaube ich, eine der emotionalsten Moderationen, die ich die letzten Jahre gehört habe, so voller Spirit. Und in diesem Geist hast du diese Moderation noch weitergeführt. Also das war fantastisch, ganz einfach. Ja, und dann möchte ich dem Markus auch nochmal, Markus Berger, wer ihn noch nicht kennt, ich meine, ohne Markus, ich habe gesagt, Markus, du organisierst das, ich bin außen vor und wir sehen, dass er das alles so toll organisiert hat. Es hat wenig geknirscht in den Abläufen, die Zeitpunkte, die Rednerdisziplin, das Essen, die Vorbereitung, die Stände, die Fragen des Hotels. Also ich glaube, was fantastisch, was du hier geleistet hast als ein One-Man-Show ohne Team. Das geht so, kann keiner leisten. Ja, dann, ihr habt schon bei mir geklatscht, ich möchte aber sagen, ich habe noch nie eine so gute Konferenz erlebt. Also das muss ich sagen, ich bin viel in der Welt unterwegs gewesen und diese Mischung der Wissenschaftlichkeit, also wer hier nicht war, der hat echt was verpasst. Das muss ich euch echt sagen. Das war auf hochwissenschaftlichem Niveau, die Redner, auch evidenzbasiert, vor allen Dingen, es war wenig Marketing, wenig Werbung drin, fand ich ganz fantastisch. Gut, wir sind nicht in Amerika, in den USA, aber diese Quintessenz, diese Schlüsse, die sich für viele von euch jetzt schließen werden, was ihr auch vielleicht neu mit nach Hause sagt, tragt das bitte an alle Kolleginnen und Kollegen, an alle Therapeuten, an alle Arbeitsgruppen, ob das Deutsche Borreliose-Gesellschaft ist, ob das, die auch uns toll unterstützt hat, ob das natürlich auch die Patientenvertretungen sind. Wir müssen einfach das weitertragen. Wir sind klein, aber wir expandieren das. Wow, was wir hier geleistet haben, alle zusammen, das ist fantastisch und tragt das weiter. Und ich kann euch versprechen, das war noch nicht die letzte Konferenz. Das geht weiter. Wir machen weiter. Und ihr seid alle unsere Freunde geworden, bitte. Ihr werdet unsere Freunde bleiben. wo wir euch helfen können. Wir halten alle zusammen, wir sind immer bei euch. In diesem Sinne wünsche ich eine wundervolle, gesunde Nachhausefahrt euren Familien, die euch leider nicht zu Hause hatten, weiß ich, mit den Strapazen. Kommt gut nach Hause und wir bleiben in Verbindung, wir sehen uns wieder. In diesem Sinne, ich bin so dankbar, dass ihr alle da wart.